So I'll make a wee start. You're all very welcome, and hope everybody enjoyed their visit to Newry last week. Today's business, we have an oral briefing from the Royal College of GPs and the British Medical Association GP Committee, who will be giving an overview of general practice. Then we have a briefing from the British Association of Social Workers on the review of children's social care services. The committee will then also be asked to consider a statutory rule on firefighters' pension schemes, and will consider written briefings from the Department on general dental services reform and Encompass. The meeting is now open to the public. Just to remind members that the committee meeting will be recorded and broadcast throughout Parliament buildings and online, and also that you are welcome to use mobile devices as long as they're in airplane mode and all devices are muted, and it's not permitted to take photographs or record any of the meeting. I have received one apology from Linda Dillon. I also have Danny Donnelly, who has joined us online, and Alan Chambers and potentially Orlia will be joining us online as well. Are members aware of any other apologies at this stage? No? Okay. I have no chairperson's business at this stage. We could refer you then to the draft minutes of the meeting held on the 23rd of January 2025, page 6 of your pack. Are members content to agree the minutes? Yeah. Okay. And I have no matters arising. Nuala?
Yes, Chair, just acknowledging that last week it wasn't open to the public in terms of coming to view, and there's just audio of it, but I just wanted to highlight regarding the visit to Daisy Hill by the Southern Trust. I think it was a great visit, and especially learning the home care, the care at home package that they deliver, and also about the medical ambulatory service. I think that was actually two really great things to learn, and all about how the elective surgery is moving there. So I think it was just a really good engagement, and just to thank them for it as well.
Oh, absolutely, and I would echo your comments, Nuala. I think it was an excellent visit, and I think it was, for a change, something really positive to see some of the really excellent work that's ongoing to try and not only have better outcomes for patients but alleviate the pressures, and there's really good solutions there that I hope that the Minister and the Department are considering. Okay.
Are we considering a visit at all to the Southwest Acute Hospital maybe for a meeting? Because it might be nice to see a hospital. It's a big building but maybe not much in it, and that might give us a contrast to some of the buildings that do have things in it. But it might be nice as well to give us a geographical perspective then, if there's sort of, we've done Foyle, Belfast, Daisy Hill, but over that direction as well, but maybe not immediately, but somewhere just in the work programme.
Yeah, no problem. Thanks for that, Colin. Okay, members, our first briefing then. We have representatives from the Royal College of GPs Northern Ireland and the British Medical Association GP Committee for Northern Ireland. So you're all very welcome back. Good to see you. Members, we have a briefing paper at tab 5 of your pack from the Royal College, page 14, and from the BMA at page 25. So I'd like to welcome Dr Ursula Mason, Chairperson of the Royal College of General Practitioners, Dr John Goodrick, Deputy Chairperson, Dr Francis O'Hagan, Chairperson of the BMA GP Committee, and Dr Kieran Mullen, Deputy Chairperson of the BMA GP Committee. So thank you all for your time. We really appreciate you being here. We have about an hour for this session, so if you want to make your opening remarks, then we'll open up for questions. Thank you.
That's fine. I'll start on the side. So, good afternoon, committee, and thank you for the kind invitation for coming today. As Liz has said, my name is Dr Francis O'Hagan. I'm the chair of the GP General Practitioners Committee. I'm a practicing GP and senior partner in the Friary Surgery in Armagh. With me today is my deputy, and I'll let Kieran introduce himself.
I'm Dr Kieran Mullen. I'm a GP in Strabane. Have been a GP partner there for 23 odd years. So, yeah, thanks for the opportunity to speak.
Today you have received a briefing paper from ourselves, and I would like to outline our position in the committee prior to some questions. So the BMA's NIGPC is distinct from the Royal College. Our colleagues here, we consider all and act on all on contractual matters, and that's what Kieran and I will specifically address. We were last at the committee in the summer, and at that stage we said general practice was in crisis. Unfortunately, that remains unchanged. The situation was untenable then, and without any urgent action going forward, the issues I identify today, it will get worse. There's no question. I will speak first about indemnity, because it is a very hot topic, and it's an issue we know that has been of interest to the committee. We remain at present the only health service GPs in the UK responsible for our own high cost indemnity, and resolving this is a key for all of our members. The Minister has taken our concerns on indemnity seriously and has committed to the Department finding a solution, and he has been on record to say that he would bring a proposal by the end of December 24. We did indeed receive a paper on the 10th of January, which our committee is currently considering in detail. However, at this stage we have some problems with the proposal. We don't believe the funding is enough. We don't know what methodology the Department has used to work out the figure, and there's only one proposal presented to us. Other proposals, we have been told, have been ruled out by the Department, but we have not shared the detail with us how this would have enabled us to appropriately respond. Whilst we appreciate there's commercial sensitivities, the overarching detail would have helped us come to a proper conclusion. The second problem we have is that we believe that it should be given out based on the number of GPs, because it is the GP's own indemnity. There's proposing to give it out per practice numbers, so we would continue to discuss that concern with them. We also believe that we are very glad that there is a mechanism for uplift built into the offer, but we are not sure that the mechanism that they're proposing to use, i.e. DDRB, is necessarily the right one, in that we feel there needs to be some link to real-time costs that we see going forward. And another concern of ours is that the local and sessional GPs are not included in this offer. Our next area of concern is the increase in employers' national insurance contributions, which I'm sure will come as no surprise to you. It is an immense concern for GPs. Every practice employs a wide number of staff: admin, nurses, salaried doctors, cleaning, and so on. This is a significant cost and we just simply can't afford it. Ideally, our ideal solution would be that the Treasury would ensure that general practice is exempt. But failing that, we would call on the Department to provide additional funding for reimbursement on a recurrent basis, which matches the actual costs. That's not our preferred way, because we don't want to see that has been an increase or a possible increase in funding, when actually it's not going to be an increase in funding, because it's going straight back out the other way. April's fast approaching and we need an urgent solution. One of the solutions, obviously, if there's nothing coming, is to look at your staffing, and if people are to be made redundant or staffing reduced, we need to give our staff enough notice. So we need to have word of what's going to happen. Without a solution, there is no doubt we are going to see a reduction in services. There's just no other way we can do this. We have no other method of charging patients. In fact, we're explicitly not allowed to charge our own patients. And our other risk is that some practices will be so badly affected that we will actually see closures. And some of the practices run by the CICs, where all their staff, their medical staff, are employed in a salaried role, they're at obviously huge risk. And of course, if you reduce staffing, that's going to have a negative impact on access. On funding, it's the BMA's position that an absolute minimum of 10% of the health budget, and that's a minimum, should be spent in general practice. Members will be aware that the Audit Office said that 2 years ago it stood at 5.4%. We suspect that has dropped in relative terms. This is the lowest investment in general practice of any of the nations in percentage terms. We are aware that Scotland has made an announcement for additional funding on Monday, and we're also been made aware that Wales are due to make an announcement this afternoon. We believe, or certainly we know for sure, that Scotland have said that they want to move more into the community. We absolutely believe that, and want to support GPs, and we believe Wales are going to come out and say the same. General practice has always been best placed to be the first point of contact for people. The Minister's desire to shift left, as I said, we wholeheartedly agree with, but we simply can't do this unless we invest resources into general practice to do that additional work. We have asked the department last year and continue to have the same ask of the department that if we got 10%, we know if we got 10% in one go, we wouldn't be able to manage that. But we're looking for a 1% increase year on year to get us to that point. Access to general practice is something that's continuously in focus, and I know you all hear about that all the time. But the problem is there has been no commensurate upturn in funding to enable us to meet the current demand, let alone any increased demand. Despite this, and contrary to popular belief, we have significantly increased the numbers of our patient consultations. In 2022, we emerged from COVID, practices saw 9.7 million patients consultations. Last year, it rose to 10.1 million consultations. That represents a 5% increase last year. 2024, we also saw the majority of our consultations back being face-to-face, well over 57%. Again, that's an increase from the previous year from 43%. Each week, general practice in Northern Ireland delivers over 200,000 consultations. I want you just to think about that. That is 10% of the population every week in general practice. So that's something I think that's very powerful. So there's still much to do. Investment is the key. We believe the best way to improve access would be the department to focus on increasing investment into core general practice as well as the rollout of MDTs, and also to introduce e-prescribing is a big ask for us, because that would free up a lot of time and allow us to have more access. On my final point on the multidisciplinary teams, we welcome the Minister announcing before Christmas on restarting the rollout and the bid for transformational funds. The importance of MDTs to provide stability to practices and equality across practices needs to meet our population. You know, this cannot be overstated how important it is. But remember, if there are no GPs there, there's nobody to have oversight of these very skilled professionals who we want to come and work with us. The action needs to be prioritised, and the funding for the rollout must be recurrent, because as far as we're aware, it's been bid for through transformational funding, which isn't recurrent. Before I finish and hand over to Ursula, I wish to reiterate as well that the MDT expansion, the GMS contract for 25-26 must include solutions for indemnity, employers' national insurance, and as important as all that, an increase in core funding so that we can be enabled to do more. Anything else, I'm sorry to say, will result in further practice closures. Thank you very much.
Thank you, Frances.
Thanks, Frances. Thank you, members, for the opportunity to come today to give evidence. I'm Ursula Mason, Chair of Northern Ireland Council of Royal College of GPs, and I'll let my colleague John introduce himself.
John Goodrich. I'm a GP partner in Ahochel since 2010 and Vice Chair at the college.
You'll not be surprised that Frances and I will sing largely from the same hymn sheet, and much of what I talk about she has mentioned, but I will try to give, I suppose, our view from a college perspective and perhaps a little bit of a different slant. 9 months ago, when we came here, we were outlining the crisis in general practice, and we set out the underfunding, the lack of a workforce plan, the lack of access for patients, the burnout and the moral injury that GPs and their teams were suffering day and daily. I spoke about the very stark health inequalities that exist across our population and the resulting poor health outcomes that come associated with deprivation. I outlined what good looks like in terms of a well-resourced general practice that delivers timely, effective care built on relationships with patients, of continuity of care, and if that were a drug, it would be licensed to treat absolutely everybody based on the health benefits for patients of having this kind of good general practice. The workforce challenges set out then remain as stark as ever. We have fewer whole-time equivalent GPs than a decade ago, and those GPs are working at a greater intensity, seeing more complexity, more morbidity than ever before. Workload has already shifted left and creeping away over that time, but it's underfunded and under-resourced and remains so. GP recruitment numbers remain stalled despite evidence to the contrary of needing an increase incrementally. Getting from the current 121 to beyond 161 over the next few years would still return us only to the whole time equivalent numbers that we had back in 2014, and yet there is no plan to move in that direction. Early career GPs are still voting with their feet and leaving to work where terms and conditions are better and where they can reliably do more for their patients than they can do here. Mid-career GPs are burning out and leaving early, and late career GPs are making the decision to go still. 9 months ago, we were on the cusp of releasing our retention strategy with short to medium term solutions aimed at keeping hard-working GPs within our workforce, make staying here in Northern Ireland an attractive option for GPs elsewhere, and importantly for our GPs of the future. Our retention strategy came then with a health warning. It wouldn't be worth the paper it was written on without significant additional investment in general practice and without a workforce plan that was fully resourced and enacted. To my knowledge, such a plan, or indeed an overarching strategy for general practice, is yet to be initiated. In fact, while our system appears to be awash with strategies, there remains an absence of one relating to general practice, the very place where most of a patient's health needs are met within their lifetime. Of our 17 recommendations, the vast majority have not been implemented. As Francis has mentioned, we are yet to secure a region-wide indemnity solution. GPs and other clinicians here have no access to a dedicated practitioner health programme when their health is failing. We await further announcements regarding MDT, and our waiting list remains such a huge burden when it comes to our day-to-day work. Digital progression across other parts of the system has been prioritised over that within general practice. And in 2025, we are still printing paper prescriptions that are collected by patients in pharmacies, travelling back and forth in vehicles. And quite apart from the safety implications for prescribing, the irony is that those thousands of green bits of paper issued every day are anything but green. There have been some positives. We've seen a modest increase in the fellowship scheme numbers, and in the realms of the primary and secondary care interface work, we have seen an engagement and a commitment to work to improve this. But when it comes to funding, the evidence is clear, and the well-rehearsed benefits of a resourced general practice that is beyond our current 5.4% is clear. The current health budget is simply not sufficient to keep the doors open and the lights on, as Francis has said, let alone our ability to increase capacity, concentrate on continuity and deal with complexity. In his report last year to the NHS England, Lord Darcy noted as independent contractor businesses, general practice has the best financial discipline of the entire health service family. They cannot run up huge deficits in the belief that they will be bailed out. But despite this, practices increasingly find themselves unable to meet the rising costs of basic service delivery through core GMS funding, as Francis has said. For some practices, this current funding makes the prospect of recruiting staff across GP, nursing or admin simply unaffordable, and this is going to be more difficult come April when national insurance comes to bear. Moving incrementally, as Francis has said, to beyond 10% will require that shift left happens effectively and we realise the potential of general practice, because we can provide a robust primary care to improve long-term health outcomes if adequately resourced. And that incremental 1% increase would create enough stability over the next couple of years to start to turn the corner. This cannot wait for a multi-year budget. It needs to be enacted now. 9 months on from when we were last here, are we in a better place? I'm afraid if you ask your constituents up and down the country, they would agree with me when I say, I don't think so. We all know that access is the number one word in our communities when it comes to general practice, but it can mean different things to different people. Is it just getting through on the phone? Is it being signposted to self-help, self-care or self-referral? Or is it securing a GP appointment? Those 200,000 patients seen each week that Francis mentioned, almost half of our population getting at some type of appointment every single month. We have greater access and capacity now than we did pre-pandemic. The real challenge, though, is that the demand has risen and it is outstripping our capacity. The 8:30 a.m. scramble on the phone each morning that our patients endure is our equivalent of the overcrowded emergency departments. The countless people sitting at home not able to get through or told, sorry, no more appointments today, emergencies only, please phone back tomorrow. That's our equivalent of ambulances stacking up outside EDs. The difficulty is that we can't even reliably count that demand, let alone film it and put it on the media. But it's there, and some of you will have witnessed it when you came to visit a local practice with us in the recent past. Our problem is not flow, it is capacity, and that relates directly to the number of GPs and the sizes of the wider practice team. It doesn't matter how many phone lines I have if I don't have a call navigator to answer them, and I don't have a GP at the end of it to see the patient when they need it. Yet GPs are regularly working beyond safe limits, and sustaining this is compounding our burnout and isn't good for patient care in the long term. We're worried about what we might be missing, what additional red flags are out there, what ill health we're contributing to by not being able to meet that need. And yet that march of demand capacity mismatch goes on. Our ageing population needs more and more healthcare, but we don't have the capacity to deal with that appropriately. We can't focus on routine, we can't focus on long-term conditions, and we're unable to take steps around preventative care that could actually make a huge difference and improve our patients' lives and make our workload less. There's no denying that endless capacity is not the answer, but it's clear from what we see every day and what you hear about every day, we need to move the dial to increase the capacity somewhat, and we need to increase the workforce, but that needs more investment. I think finally it's important to recognise that I'm going to highlight some red flags. Contract handbacks are a red flag to the system, and with 29 in the last few years, the signals are clear. Underfunding is a major factor in destabilisation, and recruitment is a major challenge. Until very recently, unlike England, Scotland and Wales, we had operated across the region with only independent contractors. Bearing in mind what Lord Darcy has said, those growing contract handbacks, however, have resulted in a growing mixed model of GP care delivery in the form of trust-run and CIC practices. I don't have any access to the data on running a trust-run practice, but I do know the cost of running a salaried service is at least 30% more than an independent contractor, and that's with evidence from Wales, and certainly early data from the CIC practices would back that up. Can we really afford to do that? Do we want to prioritise that ahead of an effective independent contractor model? Another red flag is the increasing evidence of a two-tier system of care. Patients are paying for consultant-led care due to waiting lists, even when they can ill afford it. But now increasingly they are paying for private general practice care because the NHS capacity that we have is not meeting the need. That's patients making up that funding gap on a personal level from their own pocket. But what about those in your constituencies who cannot afford to do that? The health inequalities gap is widening. If the goal is to strengthen and support primary care as set out in the 3-year plan, then the action must be to ensure that general practice is fit for purpose, adequately resourced to meet population needs with equity and with a focus on proportionate universalism. There's no doubt that competing demands exist. That said, the system needs not just to recognise the value of robust general practice, it needs to pivot resource and focus on investing in preventative care to save more in the long term. Last October, Professor Bangoa highlighted that difficult decisions needed to be made, not least to prioritise community investment. The question can no longer be asked, how long can general practice wait? The red flags are signalling the need for action now. We cannot ignore evidence that investment in general practice is a key driver in creating a healthier population, and importantly, others across these islands, as Francis has mentioned, are already taking steps to address historical underfunding, with plans to shift resource to community-based care, digitally enabled, and a focus on prevention. We cannot be left behind. GPs want what patients want and what they deserve, and that's good access in a free at the point of need general practice, not us firefighting urgent demand with limited capacity and constrained in our ability to do what we do best. Thank you.
Thank you, Yarsha, and thank you, Francis, for those introductions. I think they've been very helpful, but I think it's actually it's quite sad to think that the last time you were here we were talking about a lot of the same issues, probably further the worsened since then. So I suppose, I mean, there's a number of and we've now got the national insurance contributions issue thrown into the mix as well, which definitely makes things even more challenging. And I know from the executive's point of view that has been highlighted strongly with the British government as well, but obviously we've had nothing back at this stage to see what if any solutions are coming forward. But that has certainly been something we're hearing at all levels. Some of us met with community pharmacy this week as well, and they'd also highlighted their concerns and the impact of that too. And it goes back to that piece around the importance of primary care and how crucial it is, and obviously they're being worst hit. The primary care sector is. So I mean, the first point I wanted to make is in relation to the funding. And Ursula, I have been out visiting and meeting with GP practices, and to be perfectly honest, it's been a real eye-opener. I think I always thought I knew what GP practices did, but let me tell you, it was a real insight into the huge amount of work that goes on, not least the numbers of consultations, but things, the admin job of a GP, as an employer, managing a practice in terms of staffing and everything else in between. And in many cases, it's left to a small number of people, maybe one person in some cases. So for me, not just as an elected rep, not just as chair of this committee, but as an ordinary citizen, it was definitely a real eye-opener. And I can understand why we are seeing the issues now in terms of recruitment and retention, because I think it's a thankless job in many ways, because people don't see that huge volume of work. What many of us just see is whether it's if you get through and you have an appointment, you see your GP for a few minutes, 8 minutes, and they're trying to do as much in that time, write up their notes, then you go out and you think then you get a prescription, whatever way it ends up. But there's a hell of a lot more that goes on behind the scenes. And I think you've mentioned in the opening remarks as well, in terms of, you know, that inability because of the capacity issues to do routine bloods and routine things that should be done on a regular basis, and the management of those long-term chronic illnesses. It is very much firefighting, and also that inequity where you maybe have a practice with more GPs who have a bit more capacity and are, you know, people are getting a different experience to those that are really struggling with maybe one or two GPs running a practice for thousands of patients. And it's just a constant crisis management. So that's a message I want to come out of today very, very clear, because I know how challenging it is. I understand the frustrations the public have, but I think for GPs, we know in the last sessions that we had, that moral injury and how people can feel so demoralised by some of the commentary around it. Like something that really strikes me, and I'm probably digressing a wee bit, but one of the GPs I spoke to said that she doesn't like to tell anybody she's a GP anymore, and that struck me because of that constant negativity. She don't see anyone, don't answer the call, we can't get through, and that must be very difficult. You know, so when you're doing your best, and I mean the workload doesn't end at 3 or 4 o'clock that day, and it doesn't end when you go home either for many. So I think it's very important to acknowledge that from the outset. The funding then, I suppose, is an issue that, I mean, and Ursula, even last year whenever you'd launched the Workforce Fit for the Future report, and we're all very optimistic because we see what's needed, the solutions were there, but we're still no further on. I mean, in terms of the engagement with the department, what has that been like in terms of even that 1% year on year? I mean, I think that's a very reasonable ask, Francis. So what feedback have you been getting in relation to that? Is it something they're considering, or is there any sort of positive signs around the potential for you know, increased funding?
I mean, I think if I start and then Francis will talk about the contractual side of things. I mean, we all recognise that this is a very challenged financial environment, and I think when we talk about increase in funding, often you get, well, there isn't any money, and we know there's not any money, and I suppose the question is there money that can be shifted? So in a constrained financial environment, either the decision is made to keep with the status quo and to keep those funding, I suppose, envelopes in the separate places within which they currently reside, or is there an appetite to say, well, do you know, we actually do need to shift our focus into community, and we can't wait for extra money. We've got to actually use what we have now in a different way. And I think the challenge is perhaps when we're having conversations that's maybe not necessarily been on the cards. It's well, perhaps if we get a bit more money, we'll be able to focus a bit more on community care or on general practice or whatever that might be. And I suppose my concern is that we don't have the time for that actually within a constrained financial situation, there has to be a decision about where that money is best spent. And the difficulty is that if you spend it in one place, you can't spend it in another. And I know that you will probably hear from lots of different people as they sit in these chairs and make their case for additional funding. And the difficult decisions are made by those who have to apportion that funding. What I suppose the argument that we're trying to make is that by investing in general practice, you can potentially save money in the future. So I'll give you an example. If I said to you, would you rather in 15 years be taken very quickly in an ambulance to a hospital with chest pain, be told that you've had a heart attack, have state-of-the-art angiography and a stent, and be on 5 medications and think, what a wonderful health service I have. It's hugely responsive. It did what I needed at the time, and it gave me the treatment that I needed. Would you rather have that? Or would you rather get to 15 years from now and never have had a heart attack in the first place, and every other part of your community have lower levels of heart attacks or whatever that disease might be? Because where prevention makes a difference is it actually stops you needing the shiny hospital and the responsive ambulance. And if we can prevent more people doing that, then we need less money in the shiny hospital and for the ambulance. The difficulty is within the current constrained budgets, there are people having heart attacks at the moment that need help, and we need to be able to make sure that we can prioritise effectively. So I'm not saying that we don't treat people in the hospital. I'm saying that maybe we need to think about how can we shift a little bit of that money into prevention, how can we shift a little bit of that resource into the community to get upstream and to save money in the future. And that's a huge challenge, and that's the challenge that those conversations that we're trying to have all the time. But from an actual funding perspective, Francis will probably talk about the contract.
Yeah, well, we're in active negotiations with the department, so obviously we're not at liberty to divulge the details, but the principles, yes. If you know what we're looking for a 1% increase in the total budget. We're not asking for the budget to increase. We're asking that our percentage of it increases. Yep. So that's going along with what Ursula says. And a colleague of mine frequently says that the cars are parked on the wrong side of the car park in the hospital. They should be pointing towards the community. So there's an element of moving stuff out to the community, and that encompasses your things like your acute care at home, and more services being delivered closer to home, also your MDTs. But the thing you've got to remember then is that you still have to bolster up GP core services, because if we're going to deal with more people in the community, elderly, more people with more comorbidities, we need more GPs as well as MDT. And I mean, I actually deferred to Kieran, because Kieran has an MDT service, to just let you know what needs to get an MDT up and running.
Yeah, so fortunately I was one of the parts of Northern Ireland that got an early fully functional MDT. It's up and running. It gives us extra capacity. It works very well. It's not without its challenges. You do need, as Francis alluded to earlier, that core GP numbers to provide the clinical leadership and the practices that you're setting up your MDT members. But it works. The problem is it hasn't been rolled out, across Northern Ireland as quick as we've needed to, and we need to then develop that further. The other thing on all our committees, I'm sitting here with Francis and Ursula, who don't have an MDT, and frequently then the light is shown on how that inequity that's there, and ultimately where we can see something that works and is effective. And you had mentioned as well in terms of then how do you attract and retain staff. If you have a practice that has a well-established MDT, has a core functioning number of GPs working together with all the other staff that you need within a practice, if that works well, then how do the practices that are starting to struggle and get into a bit of difficulty, how then do you basically then look after those practices? And it does come down again, not only to the MDT rollout being faster and more widespread, the core funding must happen so that you have the core number of GPs in each surgery and working well.
Yeah. And to answer your question on the specifically on the 1%, whilst it has been an ask of ours, a very public ask of ours from last year, we're not yet it hasn't yet been brought into negotiations by the department.
I think John's probably going to talk a wee bit about MDTs and what it's like not to have one, because Kieran has mentioned the impact on recruitment and retention. But when we talk about access in the day job, I'll let you.
Well, yeah, you're aware there's 17 federation areas in Northern Ireland, just one with a full MDT, 6 with partial rollout and 10 with none. And my practice just outside Ballymena, we're an area with no MDT. The 3 main areas that MDTs would be anticipated to cover: physiotherapy, which is your musculoskeletal stuff that appears in every list you do, that's a very common thing; mental health services and social work services. The latter 2 aren't so large by number of contacts, but they are very time consuming when they do contact, and a couple of mental health contacts in the day can really throw your list off quite badly. It's difficult, and at times it's quite emotionally draining. Now, we don't have an MDT, so the GPs in my practice, we have to absorb that and deal with that. It would be so helpful to be able to pass a proportion of that work to an appropriate practitioner in the same building, and we've expanded in readiness for this. We are MDT ready in a Hochel, and that would free our time to deal with other things, because as Francis has shared, a lot of the work that we do, and as the chair had alluded to earlier, isn't just that patient-facing consulting role. There's so much about practice management, about dealing with reports, results, referrals. And at the moment, that work is in the margins of the day. You come in early, you work through lunch, you take some home, and now with remote access you can do it on a Saturday morning from your study as well. But it is not sustainable, and there is an inequity is developing across Northern Ireland now, where some practices have this, some do not. And there's a pull there for young GPs, locums, and those who aspire to partnership to migrate towards the MDT areas, where they will have probably a better standard of working life and a better balance of working life.
No, thank you for that, John. I suppose just on the point of the MDTs, and I've met the GP Federation Southern one, and I've spoke to GPs in different practices and compared the difference. And another element, you referenced around the mental health practitioner, and that is a very valid point. Having someone who is specialised in dealing with mental health issues is so important, and can just make a huge difference, not just even for capacity, but for the patient.
Yeah.
For them to be able to get that access there and then. And I suppose likewise, we recently met as a committee with versus arthritis, and about the musculoskeletal conditions. So in terms of the physio, how do you view that role in terms of the progress of that role being rolled out, and in comparison from an MD or a surgery that doesn't have an MDT with a physio, or even a partial MDT with a physio to others, and in terms of, I suppose, then the in stabilising practices, because I think a lot of people would come in with chronic issues like that, and if you have a physio on site, I'm assuming then that would make it
There is
huge
some
difference.
evidence that has been gathered around the, I suppose, consultation rates and referral rates, particularly around physiotherapy, because it's the kind of, see, support and go. Mental health's a little bit different, social work's a little bit different, but the evidence emerging around physiotherapy is that it reduces the number of appointments that patients need to deal with their musculoskeletal condition, and it also reduces prescribing around analgesics. And so I think that's important to hold on to when we're thinking about, well, how do we make it better for patients? Because John's talked about sort of the impact on GPs, and Kieran's talked about, I suppose, that sort of impact on that sort of supervisory aspect and having the core general practice. But ultimately, it's better for patients. They get better care, and they get it in a more timely fashion. But right across Northern Ireland at the minute, there's a huge inequity about that ability to access that. So patients in my practice can't get any access to that, and will probably be the last federation area to get an MDT. But we neighbour a practice in Saintfield. My practice is carried off, and 5 miles down the road is Saintfield, and they do have a full MDT. And I can have a patient who lives on the same road, in fact being a neighbour to another patient. They're registered in 2 different practices because our areas sort of cross over. And if they both get back pain, one of them gets a completely different service to another. And we can't really afford to continue with that postcode lottery.
As well as that, it's about the patient journey. If you bring this back to yourself as a patient, if you have a mental health problem and you get early intervention, it's much, much more likely that your long-term outcome is much better and you have less likely of your condition become chronic. And it's the same with the physio. But the mental health one, I think, is really stark. Because if you can get that early intervention, rather than going on a waiting list to see a counsellor or whatever, that can very much turn the journey around, in conjunction, obviously, with the GP if you do need medication. But it's just where that patient ends up on their outcome. And their outcome, whilst outcomes are on waiting lists for physiotherapy and medication, it's also the patient's productivity and being able to get back into work and, be, a person in society that's given back to society, as opposed to somebody who's off and their condition is deteriorating whilst we're waiting on somebody that could be in my surgery. And like that, I don't have an MDT either.
Yeah, and I suppose just on that point then, it goes to that bigger point of investing in primary care and investing to save. If people are being seen by physio or mental health practitioner, social worker at that point, rather than their GP, who probably at whatever, if that's the issue, then it's not the appropriate place for them to go. Then that's an investment to save. But if they're on a waiting list, for example, if they're being referred to physio on a waiting list during that period and they're in a lot of pain, they're coming back to their GP, they're coming back for prescriptions and all of those. And likewise, I think that the analogy you gave earlier, Ursula, of avoiding a heart attack or a heart issue 15 years down the line is huge. And I think that the longer we go on the way we are, with all of the money is going to have to be directed into acute services, because everybody is going to be at a crisis. So I think those are really, really important points. I have other questions, but I think we've covered a lot, so I'm going to move on to other members. So thank you all for that. Nuala?
Thank you very much for your presentation and for coming again. I know that we've had opportunities to engage over the past few months as well. I want to focus on indemnity and as well, just the first instance. When I was reading this last night, and I appreciate that there is an ongoing negotiations, I fully appreciate that, and I will propose to the chair that if we as a committee write to the Health Minister to ask if he can give us more information. So one option. And did he say, or was there anything presented, or was there any ongoing back and forth why any other option wouldn't work? Was there?
No, we were presented with one option, which was a figure, and that it would be given out, how it would be given out and how it would be uplifted in the future. But how we got to that figure or why other options were discounted, no, we weren't given that information.
And with regard to your feedback into the department, did you feed in, this is what we would like to see?
Yes.
And so there was no comments or anything back on any of that?
Well, we have with the last meeting of our team with the department was just a few days after we got the letter of offer. So we've had time to take it away. We've discussed it with NIGPC and we've come back with these concerns. Our next meeting is due in about 2 weeks. And we intend to take the concerns. There has been some informal contact back, but we need to take it formally into the negotiations to see can we get both some more information and also what we believe to be a better offer.
It doesn't really scream to me to be co-design or negotiation, what that word actually is, how that word's defined, if it's just a one-way system, which is really disappointing. But not at all surprising, and hopefully we can maybe get more information too. With regards
I have to say that after I think it's nearly 10 years, I'm delighted to have something to start with. I really am.
That's good.
Yeah, and I think we would accept that there are other models of indemnity in the other UK nations that basically gives an opportunity here to pull from that experience and the other models that are there. So we don't underestimate there was a certain amount of work that went on to get to that offer, but we need to develop it. We're very clearly we're driving that. Yeah.
And we of course also appreciate that with the funding issues, but like you say, it's about shifting the funding as well. And unfortunately, the department it seems very afraid of the do anything different, which is disappointing. If this current offer was accepted, how much of a disparity would there be amongst GPs, locums and anyone who isn't covered? Because I understand locums aren't included, is that correct?
Locums at this moment in time in the offer, locums are not included, and we represent all GPs. So
do you think that's that's purposely done by the department to kind of entice more doctors into kind of permanent places rather than
that's what they tell us? Yes, that's exactly what they tell us.
Yeah. But what do you think could work to entice more locum GPs into permanent positions instead?
I think I'm going to harp back to this the whole way through this. Increase our core funding. Yes, of course, increase the funding for the community work as well, but don't forget the core. Unless we have better terms and conditions and we have more money to employ more doctors and bring them in to the independent contractor status, we are never going to get where we need to be. We're not going to even keep pace with our current demand of access, let alone being able to do other things that people want to move out to us, which we believe those things are better done in the community. There's no question about it. MDTs are a good example of that. But we still need the core reinforced so that we have the doctors there to be the overarching person, and also to get more doctors in so that we can do what everybody wants us to do, to have more access. And under, when we mentioned access, and you mentioned it yourself about the other things, I would extend the invitation to any member of the committee to come out and see what my practice is like. But we did in our briefing packet give you a diagram of an iceberg. And I think that if you look at that, it very clearly demonstrates the amount of work is of lifting the phone and getting an answer and or getting an appointment versus all the other work that goes on. And that other work is access. Me looking at your blood results and commenting and giving you back a plan of treatment is access. Me looking at your hospital letters and acting on that, calling you in for something else, that is access. Me bringing you in to our nurse and getting your diabetes bloods done and getting your annual check done is access. I'm sorry, all those things in that iceberg are access. But it's not the terminology that is batted back at us. Access out there seems to only be, couched in the terms of answer the phone and get an appointment. There is so much more, and we thought that diagram is actually, quite good at demonstrating what we want to say.
And I can attest to that. I did also visit North Belfast practices on a particularly busy day, and one thing that I did notice and what should be highlighted again is the priorities. The GPs have to prioritise the very sick ones who call in, and often the frail and elderly who are maybe not as able as others to contact, and I did see that on the ground, and it was great work, and I think that's worth exploring in almost, if there's any capacity to campaign on a wider issue.
And that's why triage works. It's not just about fastest finger first. Just because you're first on the list does not mean you'll be phoned back first. You'll be phoned back first depending on what you tell the receptionist about what your condition is that day. It's not the receptionists are being nosy. I mean, if you go to A&E, you tell the receptionist in A&E what's wrong with you. If you want a dental appointment, you'll tell the dentalist receptionist what's wrong with you. So you need to be able to tell us the truth. It doesn't have to be a huge amount of detail, but we need to know. For that reason, we're skimming up and down the list. Chest pain, right, okay. Very short of breath, yes. Want to talk about my report last week from, a consultant. Well, that can wait a wee while. Want to talk about my cholesterol result? Yeah, we'll get there, but, we need to find these other people and get them in first.
I think one of the challenges, though, and appreciating that our public and each individual, their health is very private, and when you're in a big faceless hospital talking to someone that you're probably never going to see again, it's so much easier to impart that information. We're very much at the heart of the communities that we serve, and I think the reception team and perhaps the nursing team and even the GPs live and work in those communities, and so it becomes a much more personal thing. But I suppose if some of the messages that we can get across to the public around this is actually to help you get better care in a more timely fashion, and that our care navigators or reception teams, they're highly trained, they're completely confidential, and I think that's again something which people forget, and they think it's, well, just because I meet that person in the schoolyard or I know who their granny is, they're going to impart my medical knowledge. That is not the case. We all work under very strict confidentiality codes, and it is something that we need to get out to our public, that in giving that information and in us enacting a degree of clinical triage or telephone consultations, it allows us to be more flexible, it allows us to see more patients. If I think about how we modelled our patient access 10 years ago compared to now, I probably see at least 30% more patients every single session, because I can do that and because that information helps me to prioritise. So we are getting more from the system by doing it, but it feels like it's a retrograde step for our society. Unfortunately, in that capacity constrained system, it's the only way that we can operate and see as many as we can with the people that we have. To do more, we need more.
Thank you, and I think that is key, going back to the contract negotiations and the core funding. I think I suspect it's similar to, the indemnity negotiations. So I think there needs to be a bit of a key change in how we negotiate, to be honest as well. We understand, both sides always understand, not everyone will get everything they've absolutely asked for, but I do think there needs to be a bit of a change, because the public are very much watching and
the idea as well that we cannot be left behind. We're watching very carefully to see what Wales announced today, and we're led to believe it may well be significant. Scotland have put additionality in, England's looking at it. We cannot be the only ones left behind with no additionality in our core funding, because we're already the worst as it stands.
And can I just, my final thing is, and I don't expect you to answer today, it's something we can perhaps engage on further, is that change within how we spend the overall health budget and decisions that need to be taken, that it would be interesting to hear, from experts and people who carry out the work of the health service, what do you think could and should be done, or ideas to ensure that shift left is into the community financially. I don't expect you to say it here in the public committee, but I think it is worth liaising with in future.
Yeah, and just very quickly, as we're talking about budgets and things like that, an issue that was brought to my attention in the last couple of weeks, which just blew my mind, was from a nurse in a treatment room, and she said that because the consumables budget is £516, and they're in a position now that they can't buy butterfly needles. Now, I'm not a nurse or a phlebotomist or anything like that, but the impact of that is huge. And I actually contacted the department, and the response is just they're over budget and there's nothing we can do, really. I mean, that's another example.
People don't understand the amount of what we get. This is not about GP pay. This is about the budget that comes to a practice. Yeah. And people don't understand that out of that budget, I have to pay, or we all have to pay, our heat, light, staff pay, staff costs, increasing, their staff appropriately. Then you have paper, you have, everything. You have everything that goes, cleaning in the building, in the nurses, the stock in the treatment room, all that all has to be bought. If I want to do minor surgery, I have to buy the pack and the instruments to do that. Yeah. If I want to, for a lady fit a coil or an Exponon, I have to buy the pack to do that. So it's the budget that comes to us, the budget that follows that, to enable us to do it. Because what happens is, at the end of the month, the GPs that are the independent contractors, salary GPs, know what they're getting. The four of us, we have no clue what we're getting at the end of every month. We get what's left.
I think it is about, you made the point earlier, whenever we're talking about health provision and budgets, as an independent contractor, you can't go into deficit. Yeah. If you spend all your money, you just don't provide the service. It's as simple as that. So you get what you pay for, and that's basically it works. And as Ursula has alluded to, that's 30% efficiency you're getting, really, with having the independent contractor model. But that's the reality of that model. If you basically don't have the money, you basically can't provide the service, you can't get the equipment, you can't employ the staff, and it's as stark as that.
And that's the impact.
That's one
of
the
the
reasons why a lot of the contracts are going back, because it's financially unviable. So, talking to a lot of colleagues, we know that GP partners are often taking home less money at the end of the month than their salaried employees, because if their bottom line drops and they're having to buy the butterflies, because you can't take blood from a child without a butterfly, and if a child needs their blood taken, you got to take their blood. So, I mean, there are so many aspects of this that are being, I suppose, you know, the funding is being supported by the GP partners, so the time and effort that's going into running a business. And a lot of people are, and this is the voting with their feet, I can't do this anymore, I can't prop this up anymore, I can't financially take that risk anymore, because we hold clinical risk, but we also hold a huge financial risk that other parts of the system don't hold. And I think the big issue here is it wouldn't take a huge amount of additional funding in the grand scheme of things to really create that degree of stability. Because 1% is about £80 million, 0.5% is about £40 million. So when we think about a health budget that goes beyond £7 billion, that's not a huge amount of money. But that's what we need to be able to find this year and next to create some degree of stability in a system. Which actually, I mean, you know, we're all jobbing GPs. I actually really like my job. I'd like to be able to do it a wee bit better and to be able to give a wee bit more. But the reality is that until we get some degree of stability, that all we're going to find is people thinking, I don't know if I can do this anymore. We've got a very small window of opportunity, I think, to keep things on track. And I think we need to be very careful about making the best use of that time and creating that window that we can actually sort of move forward and know that we're on the right track and that GPs will stay the course.
Absolutely. Danny?
Thank you, Chair. Can you hear me okay?
Yeah.
Yeah. Thank you. And thank you so much for your presentations. It was all sadly very familiar. You know, we have heard this from yourselves when you first came into us. We've heard it on subsequent meetings since. And I'm sorry that it hasn't improved. I'm sorry that we're sitting here again today in the same situation or probably worse, given the UK budget impacts. It has been raised. It has been raised time and time again in the Assembly. We've had various debates whereby various aspects of the health service, but general practice has been mentioned as not being funded enough. The 5.4% has been raised time and time again. We tend to get irony klaxoned, which is a term that is used by the Minister just about his financial pressures, and I absolutely understand that as well. Again, in the community, access is the main issue that we get raised. Everybody talks about the access. So it is encouraging to read in the reports that the increase in consultations, and certainly that's something I'll be taking away. Having visited GPs in the local area, I know how hard they work, and I know that they're doing more consultations than they should. And I note that in the report it says 200,000 consultations a week in Northern Ireland, 10% of the population, as you outlined. That's a phenomenal figure. Every week getting a consultation. But it suggests that 85% of GPs are working beyond their contracted hours. You know, that is phenomenal, and that screams to me that the funding is too low. The 30%, alleged 30% extra cost of a salaried service, if a trust is running a GP service, it may well be running at 30% more than a normal GP service. Again, screams the funding is too low. And that even the handbags, the shocking amount of handbags, 29 handbags, again screams that the funding is too low. Two quick questions. Just what can be done within the current political and financial context just to improve working conditions for GPs? You had mentioned about health service for GPs there, something that can be done. I know it was something you had mentioned previously. Has that been progressed at all?
My knowledge, it hasn't been progressed. So this is a practitioner health programme. Again, we are the only area across the entire British Isles that do not have a practitioner or access to a practitioner health programme. We know that burnout and ill health within doctors and other allied health professionals is significant. It is very often very difficult for a doctor to approach another doctor, and particularly particularly in a small place like Northern Ireland, and particularly if you're approaching someone with issues around mental health or addiction, which is increasingly common among clinicians. So having a dedicated programme that supports doctors in a way that helps get them back on their feet, get them back into work, has shown to be hugely effective. Will prevent catastrophes like suicide, and we know that suicide rates in doctors are much higher than the general population, and in enabling our clinicians to access support like that, we would be going some way to supporting them to stay in a working environment and also to prevent that happening in the first place. So it would be hugely beneficial if we could get that over the line here. I mean, I know there's a lot of work going on behind the scenes by a group which is trying to spearhead that. So it's a group of GPs, dentists, hospital clinicians and pharmacists, and it would be a very welcome step if that could be afforded the small amount of funding that it would take to get that off the ground. There are models across England, Scotland, Wales and the Republic of Ireland all offering services for doctors and clinicians in difficulty, and we still remain behind that curve.
We'll just add something as well, which is quite important, is the primary care infrastructure. So the buildings essentially that GPs work out of, and while there is obviously a development programme year on year to try and address that, that needs to be probably bolstered in terms of finance as well and developed quicker. There are some new builds that have happened within primary care, and there are more that are planned. But in essence as well, it comes down to not only the functional teams that you're trying to attract staff into. If the buildings aren't fit for purpose, if you don't have the proper facilities within buildings, that will absolutely impact on recruitment. So that's another very live issue for us in terms of the primary care infrastructure bill that's within Northern Ireland at the minute.
Thank you. And just to go back to the practitioner health programme, is it funding that is the main barrier of this? Are there other barriers that are stopping this from progressing?
So, to my knowledge, funding is the main barrier. I mean, I think in terms of discussions thus far, I think as far as I'm aware, there is a draft business case. I don't know that it has reached as far up the chain as it needs to get in order to enact a decision. But it is my understanding that securing funding would be the most significant barrier.
It's clearly very, very important, and given the long-running intense pressures that GPs have been working under, it gets more and more important. And certainly we should see how that could be progressed, and certainly that would be something we should be raising with the Minister. Can I ask how we encourage trainee GPs to come here or to come to Northern Ireland? What would be the main barriers that they would face in being attracted to come here?
There's a lot of that,
except for everything you've mentioned.
There's a lot of information about what our trainees have said in our retention strategy, and even though we're 9 months beyond that, it still holds fairly true. We do have a significant amount of work that needs to be done in terms of attracting people to come to work in Northern Ireland, be they trainees into GP training or established GPs coming home or coming here because they feel it's a good place to live and work. We do have different terms and conditions. It's not as an attractive place to work currently. And from a trainee perspective, right across the UK, we have seen an increase in the number of international medical graduates who come to join all training programmes, and GP training is no different. We need to make Northern Ireland a welcoming place, both to train and live and work, and also a place where if you've come here from elsewhere, that you feel that you can stay, that it is a good place to stay. All of our trainees, and in particular international medical graduates, are much more mobile. And so when they get their certificate of training or their CCT, it is a ticket to travel. And if terms and conditions are better elsewhere, be that across the UK or Ireland or beyond in terms of Australia, New Zealand, Canada, wherever, that is essentially a ticket to a better life and a better work-life balance. And those people will move. And we need to make here a much more attractive place. So while we potentially can attract more people in to train, the bigger job is to retain. And that's where things like our workforce and our workload. So if your workload is inordinately much more difficult and going to cause you to burn out in 5 years here, why on earth would you not go to Australia? Because that's where you'll have a better work-life balance, and actually, you can feel that you're really doing something with your qualifications, with your career, and also just, with that need to be able to affect change and help people. So I think we have a huge amount of work to do, but we are battling against really difficult headwinds. So as Frances said, actually, if funding and investment goes into general practice elsewhere across the UK, and we know what's happening in the Republic of Ireland, I mean, it is a much more, I suppose, terms and conditions are much better. So we need to make sure that we actually can compete with the rest. I'm not even suggesting we compete with the best. We just need to be competing with the rest locally, so that we can keep the doctors that we bring here in the first place. And I think, again, it's about making sure that the environment within which we work is an effective one, and it's one which is not making us sicker and making our patients sicker.
And also, just to highlight, within retention, we have been very successful at recruiting into trainees one particular group of people, and Kieran and myself would feel it because we're in the south and the west, and international medical graduates are also classed as anybody who comes up from the Republic of Ireland. So in my practice alone, this year I have 2 trainees, one's from Laytown, one's from Bettitown. Both of them are living and travelling to me. Are they going to stay once they're trained? Not a chance, and they're 2 very good GPs. Last year, I had a girl from Dublin, and the year before that then, I had a guy who originally was from Kazakhstan, but had come up through Limerick. The only one of them who might stay is the guy that came up through Limerick. He brought his wife and children with him, and his children are now in school, and I believe he will stay. So we have that particular challenge that we don't have in other parts of the UK, is that because of our land border and our ability. And I mean, I don't blame them if they can come up here and get a training place here, if they haven't been able to get a training place in the Republic of Ireland, and they've every intention of going straight back again because the terms and conditions are better down there. So that's something we need to keep in mind, as well as the general retention.
Okay, no problem. Thank you very much for everything you're doing, and thanks for that presentation. Thank you.
Thank you, Danny. Orlia?
Thanks very much. I'm sorry that I came in slightly late and missed some of your remarks at the beginning of the meeting, Frances. So first of all, I would just like to ask the question in terms of the GP elective care service. So I could see in the briefing paper there was some detail around that, explaining that the capacity and scalability would be there if additional funding became available. And obviously, the example was used about the success of the vasectomy being transferred from secondary to primary care. And, the buzzwords there for me is cost effective, gold standard. So in a lot of the conversations that we're having with the department and the trusts and everyone that's involved in the healthcare system at present, given the financial burden and pressures that we're under, all the conversations are around, how can we make things more cost effective? How can we become more efficient? How can we take more of the pressures off the emergency departments and the hospital waiting lists? And I mean, that seems like a perfect example of how something like that can be done. So I just wanted to ask the question, are you having any conversations, and at what level, with the department, with the senior management of the trusts, to see if that is possible, where any of those additional surgeries could be transferred to GP practices? Because I definitely think there's something there.
So I think part of the answer to your question is yes, there are conversations. I suppose going back to what GP elective care was it was initially started about trying to actually level the playing field for patients in general practice and access to services that some GPs could provide, but not all, because every practice is different in terms of their skill mix. So a small GP practice who maybe wouldn't have the ability to manage women's health or do minor surgery, being able to say, look, locally we can get this done in a hub which is close to home. The upside to that is that not only are you creating additional capacity in general practice for things which can be done in general practice, you're also taking pressure off a hospital system, because before the GP elective service, that practice would have referred that patient into the hospital for that service. So those conditions were born out of, and initially what we did was we actually looked at the biggest referral rates into certain specialties, so into gynecology, into dermatology, into musculoskeletal or orthopedics, and it was the low-hanging fruit. It was the things that GPs could do, and the service was born out of that. Vasectomy was a little bit different because it was a new service. It was developed. The gold standard was that it was done the way it was done, and that GPs across the rest of the UK were doing it. So we sent some GPs over to train and do it and set the service up. And what was provided was a more level playing field, so that if you are a patient in Cullybackey, you get the same service as in Castlewellan, as in Cookstown, and that we created an environment where actually, and what we've been able to show with elective care is that actually not only is it transforming care for patients, it's bringing it closer to home, it's meeting all those buzzwords that we all talk about, but actually it's reducing health inequalities. So referral rates into GP elective care in the likes of North Belfast, where there is higher levels of deprivation, are much higher, but their needs are being met. They're being seen in their local communities closer to home. The difficulty is that the funding was cut. So the capacity that was there pre-COVID is not there now, with the exception of vasectomy. And the decision that the then Health Minister Robin Swan made to move money from secondary care to primary care, to my mind, is the first and only time that I've known that to happen, where you've actually taken funding that has been in secondary care and move it to primary care. And one of the core reasons behind that was it was more cost effective. So the same procedure, well, first of all, the procedure that was done in primary care, it wasn't being done in hospital, so gold standard wasn't being done there. But a vasectomy in hospital is costing about £1,200. It costs about £400 to do in primary care. It's a no-brainer. And if there are other aspects, and again, having conversations with individuals in the department about if there's something in a hospital setting that could be done in a community setting, there are those hubs there in place now. There are hubs right across Northern Ireland. They are in every federation area, and if we can deliver services in those hubs safely and effectively and more cost effectively, which is really important, then we of course will have those conversations and we will try to facilitate that. And if that means that that's a GP with a special interest or an enhanced skill, we'll work towards that. And if that actually means bringing other expertise from a wider multidisciplinary team into a community hub, absolutely, let's look at that, because that infrastructure is there, notwithstanding Kieran's discussion around the actual sort of wider infrastructure piece. Those hubs are there, that good governance and accountability is there, and that cost effectiveness has the potential to be harnessed even more.
And I think like this is exactly the type of stuff that we need to be moving towards, in terms of, as you said, the cost effectiveness, and even the language that you were using around the hubs and the models, the infrastructure that's already there in place, even in terms of the work that's been undertaken for a women's health action plan. And you had mentioned gynecology. We know that with the worst waiting lists across all of these islands, and probably not just for gynae, but I'm using that as an example in terms of the women's health. But again, if we're going to be launching, if the Minister, the Department's going to be launching hopefully a women's action plan soon, following consultation, where does general practice fit into that? And if there's scope to tie in some of the waiting lists from gynae?
And particularly when it comes to common gynecological conditions. So our women's health hubs were basically for long-acting contraception, menopause and HRT care, and urogynae, and they were the main things. Ironically, whenever the hubs were set up and whenever we were delivering the service, some of the colleagues from hubs had a conversation with folk from NHS England about how we were delivering women's health hubs. They have taken that model and they have run with it, and they are providing it in greater and greater quantities, and we are taking steps backwards. And so it is so disheartening to think about something which was designed and delivered and initiated here that has such a good idea that's almost been stagnated in its ability to continue to deliver. Part of the aspect of the elective care hubs was not just to deliver service for patients, but actually train GPs. So if you don't have a skill in dermatology, you can come there and train up and deliver it in your own practice, almost putting yourself out of business. The funding for that demand management side of things and the training, that was cut alongside the service delivery funding. So there's not only the option to deliver for patients, but there's also the option to actually increase the skill mix in general practice and create more capacity in your own practice. if we could get the go-ahead to move that
And
forward.
there's a word of warning in there, because you're going to say to me, on one hand, you're telling me you don't have enough GPs, yet you're going to do this other work.
And scale up, yeah.
We need to be cognizant. Yes, we can do this, and we should be doing this work. But we need. I go back to the core funding, so that we can produce GPs. And many GPs now have what they call a portfolio role, where they want to do life and general practice and life doing other things and bring that skill back. You know, and they also bringing money into the core isn't just about money, it's about funding. For the example, as well as your minor surgery. So if I go to do a knee injection on someone, I get, by the time I pay my nurse to be with me and the pack to do it, that I get around £49 for that. I mean, it's nearly 10 times that, but to get in the hospital, you know. So it's not just the elective hubs absolutely are very efficient, but we're damn efficient as well. We are really efficient. And if you put that money in to allow for GPs to grow, and we'd be able to provide more things, both at practice level and at core level, or at hub level. So it's, we need, if we're going to staff these hubs, we need more GPs back here to train, to allow them time out to go and do this other work.
Yeah, no, of course, and thanks very much for that. That was really interesting feedback, because I think even in terms of looking at those hubs and that model, like Ursula, there was an event where there were, I think it might have been the launch of the Women's Health Action Plan survey, and we had a presentation around the NHS England model, and everyone was blown away by it. And there was discussion in the room about, how much, we should be working towards a model like this and learning from the NHS model. And we're hearing today that the model originated here. So it's about, I think, recognising that, celebrating that, and using that to your argument. As you said, Francis, if you can stabilise the core funding, then you can start building, hopefully, and working towards those other really, really important projects. So,
and there are other things that, we're very focused at the minute on providing procedures and stuff. There are other things that neatly fit into being housed in general practice. For example, diabetes services, where you bring your dietitian and your diabetic expert nurse in under the community services, properly facing primary care. What we have at the minute, if somebody needs podiatry or that their cars are parked towards the hospital. They're not parked towards the community. And we have a huge problem with diabetes, and it's one of the fastest growing diseases we have, which is going to eat up a huge percentage of the budget. We should be looking to shift that. We have a respiratory hub, I think, Liz, you saw it in Moy, where we're trying to get people diagnosed, difficult clients who's not sure whether they've got COPD, whether they've got asthma, because it all overlaps, or whether they've got pulmonary fibrosis. We're trying to bring that into the GP surgeries to get those patients diagnosed earlier, and then only send the ones to the hospital that are complicated and need hospital care, rather than be sitting on hospital waiting lists to get the diagnosis made in the first place. So there's an awful lot more than just procedures that can come into primary care. But you're going to be sick hearing me saying this. We need the funding to do it.
Funding, yeah. And I suppose the other thing as well, because you have all mentioned obviously different issues in terms of health inequalities, which underpin everything that you are talking about in terms of the work that you could be doing, the preventative work that you could be doing in addressing health inequalities, and that's clear to be seen. And again, it's just to make the point that we know that the Health Minister, one of his priorities that he has set out from day one is in terms of health inequality. So it's how we use that as part of the argument to support the calls from GPs to, lift the core funding up. Because again, if that's ticking the boxes for the targets for the Minister to reduce health inequalities, then if that's a sensible thing to do, if money becomes available, or as you said earlier, Ursula, if you can move current money that you have around. I'm not saying that's an easy thing to do, but it's just important to make the case in terms of the health inequalities. It is a priority for the Health Minister, and news would clearly be able to help support him in his endeavours to deal with that. Just finally, I wanted to ask, you had mentioned, Francis, in your opening remarks in terms of, I know what it says in the briefing paper, that over half, 51% of GPs were indicating that they would be leaving general practice within the next 5 years, which is huge. And also, which really stood out was that 45%, so nearly half of all GPs, and at least once or twice a week, that they get so stressed that they feel that they can't cope. Yeah. I think that is shocking. I think in any other profession, if that data was being fed back and put into the public, it's not acceptable. Do you know what I mean? And so you can see, obviously, if GPs are crumbling, the overall system's going to crumble, and the impact is on, of course, the GP, but also on the patient. So I just wanted to ask, you had spoke about if things don't change and if the core funding doesn't increase, a reduction in services, additional closures, and essentially a reduction in people accessing general practice care. So can you just give me a sense of what those statements mean, or what you foresee that to look like? Would it be practices starting to, maybe close on certain days, maybe only open a half day, and reducing some of the services that you're already receiving at the minute? What does that mean in terms of what you think we're facing into this rabbit hole in terms of reduction in services, additional closure? What does that look like?
Right. I'll take you back to the first point you made about the figures. That was not our survey. That was a survey conducted by the Department of Health themselves. And they conducted a survey open to all GPs on the performers register, and they got responses of close to 600, which is well over half the profession. So that's really good in any survey. And I agree with you. The statistics that come out of that were frightening. And it wasn't the older GPs that were thinking about leaving. It was a lot of the younger ones. I'm at an age now where I'm an old fogey, and I could retire at the minute. I don't want to. I'm one of those ones. I still love my job. I think our job is a huge privilege. You get to walk with patients from the cradle to the grave, and they let you into their most inner troubles and secrets, and also celebrate with you at joyous times. So I actually believe it is the best job in the world. But we have to make it in such a way that we are able to allow that to flourish, and that we have enough of us to actually do the job in the way we wanted to do. I can remember what it was like when I first started out, and it was nowhere near as pressurised as it is now. Nowhere near. I've nearly 30 years in general practice, so it's and I am a grandmother now, so it's I'm seeing my own grandchild coming through as well as my children coming through. So yes, that's our aspiration. That's what we want to do. But if we don't get the funding, unfortunately, we are going to do exactly the opposite to that, and we're going to have to say, if I'm looking at a bill and I have a bill for staffing, and we've looked at our bill in our practice alone, and we're actually not too bad compared to some, because there's some way up in over 50,000. We're in a magnitude of 10,000. What is that in reality? Is that a receptionist? Is that part of a doctor? Is that part of a nurse? What is that? And that's unfortunately, because those are the only costs we can cut. We can't you can't cut how much it takes to heat the building. You can't cut the fact that you need paper and all the rest of it. So that's really our only magnitude of cuts. Or do we cut GPs? Because GPs at the end of the day are your most expensive, part of your workforce. So do you cut GPs? And if you cut GPs, that's a cut in access. If you cut girls on the desk, that's a cut in the number of people being able to answer the phone. It is absolutely not what we want to do. It is polar opposite to what we want to do. And that's why we're here today, to try and explain to you how important it is that we don't do that. It's counterintuitive, counterproductive, and I suspect strongly it's not what the public want either. And I'm sure it's not what you want for your families.
Thank you, Julia. Diane?
Yes, thank you, Chair. And first of all, my apologies for missing most of the presentation. I do apologise, but I did have a good conversation with Ursula a few weeks ago, and I think around this committee there is a huge deal of support for the work that GPs do. I think that there is a general agreement that we are better to have services delivered closer to people, closer to communities, and so on. And it's about trying to make the brave decisions that make that happen. And Nuala alluded to that, because one of the things, if you're looking at 1% increase in the overall amount that goes to GPs, in the overall context of the budget, which this year, if I read my papers correctly today, is over 8 billion that is allocated towards health, is not a huge amount of money. So you know, and I don't know why that transfer cannot take place. And as Nuala alluded to, I think it'll take, you know, braver decisions to actually make that happen. So that's my statement of intent. I mean, I think it's important to say that, and I don't think there's anybody really here not with you in relation to that, which is important as well. I just wanted to ask a couple of things that have been on my mind, having talked to some GPs, and one of it is in relation to what patients perceive as the service they get from GPs. And I think it was you, Francis, that said to it, in a constituency office, one of the most common complaints I will get is they never answer the phone. I can't get an appointment with my GP, etc., etc. Now, I'm not saying that you're not all working very hard, but I do think that that's one element. I spent a morning up with the GP surgery in Banbridge. I spent a whole afternoon for hours with the Southern Federation. I talked to GPs. This week it was GPs without electricity who couldn't actually connect with patients. So I talk to GPs quite a lot because I see the importance in people's lives, in the lives of our community. But I think that perception is really important, that we try to change that. And I suppose the other element of that is that what I see across my constituency is almost an inequitable service from GPs. So we have GPs that are now administered through the Federation or through the Trust, where it's basically a phone answering emergency service. And we have GPs, like I saw, I mean, I was at the GP surgery at 8:30 in Banbridge. It was a hive of activity. People coming and going, talking to GPs, talking to receptionists, listening to the phones going, and so on. I think it's important for people like me to do that. But it's that perception, and in some people's reality, of that, unequal access to services that I do think is a problem. And I'd really like a further conversation about how we actually tackle that, because I think that's important. Waiting lists. We have the largest waiting lists in Northern Ireland. So I'm just going to throw it all at you. It's fine. I'm sure you're
making a note
of this. We have the largest waiting lists ever in Northern Ireland. And sometimes when I talk to GPs, I get an impression of people who struggle almost with moral harm, because they know that their patient needs an investigation, but the waiting list for a neurologist is very long, or whatever the condition is. And I just would like your comment on that, and how we can actually try to improve that in a practical sense. And I understand that some kind of forum or service to GPs themselves is quite important, but I also think that there's something there that needs to be done between the Trust and GPs. I hear from GPs that they spend hours trying to chase results and all sorts of things. So why is that so inefficient?
Yeah, well, I'll start.
Sorry,
there's a lot in there. I think I'm glad you went to the GP surgery, and I would encourage as many of the committee to come along. I'll have any day, especially on a Monday morning. You're more than welcome. But and I suppose maybe GMU came out to my surgery last year and interviewed before we all got up and going, and as the girls were coming in, and they did an interview which really struck me. It was one of my receptionists called Mary, and it was just before the 8:30 rat race started, and Mary was very honest, and I was a bit taken aback myself. She says, the interviewer said to her, what are your feelings now? It's now 8:25, and Mary says, my heart's in my mouth, and I get anxiety because I worry so much that I'll not find the patients that need us. We'll not get to them, or the appointments will be gone before we do. And I think that was very telling. our staff are as anxious about, this, as Ursula rightly referred it to, the ambulance is waiting outside is our equivalent of the people who don't even get through, and the people then scrambling to get through is our waiting list in the waiting room in ED. I frequently tell patients who say to me, there's not too many in your waiting room today. And I'm going, well, hold on a second here. We have 4 doctors on. So many people did you see out there? You saw 4. And then that treatment room was down there. So we have 2 treatment room nurses on. You saw 2 people for there. And then the nurse was on, and there were 2 nurses on, and there's 2. So that's 4 and 4 and 4. Those people will all be taken in, treated, and back out. And when they're back out, there'll be another 8 in the waiting room. Okay? You multiply that every 10 minutes. If we kept everybody in our waiting room all day for 8 hours or whatever, you wouldn't get in the front door. But it's just because they're not all there at the one time. People think, sure, there's not very many here. But it's because we are appointing you, and we are taking you at the by and large at the appointed time. And if we know that you're coming with a mental health problem or something that's going to take longer, we afford ourselves more time so that we're not keeping people waiting in the waiting room. So there is I totally agree with you. There's this perception out there that A, we're doing nothing, and B, we're not answering the phone.
I don't think anybody thinks you're doing nothing, Francis.
Well,
I don't think that's the case. None of us think that at all.
No, but the public perceptions you said,
I think
you
public
can't get an
perceptions,
appointment.
we need to try to help you to change those public
absolutely
perceptions.
Yes, and that
and I'm just being honest with what I hear.
Oh yeah, and we accept that.
Yeah.
There are definitely sort of alterations in how, John's practice will manage his access differently to how my practice does it, differently to Francis's, and often that's to meet the needs of the population, but also it depends on what your staffing level is like. So if you're a practice that's been finding it really difficult to recruit and you're 2 doctors down and somebody off sick, you will change your access arrangements to meet the needs of the population in the best way that you can. So we do have an equity. We know that doctors, so the number of GPs per head of population in areas of high deprivation is lower than those in areas where there is less deprivation. It's harder to recruit in those areas, and ironically those are the patients who need more access and more service, but we don't have the ability to do that, or the funding model doesn't fit that purpose or be able to allow that to happen. The other aspect of access is that, often, as Francis has said, it's trying to meet needs where they are in the best way that you can. But again, it's what our public want from us and what they need, and we don't have that capacity. So people do get turned away, unfortunately. We'd love to be in a situation where everybody could be seen all the time when they needed it, but the simple fact of the matter is that we can't do that. So each practice tries to do the best that they can. Sometimes they've got capacity and they've got perhaps an IT infrastructure or a telephony system that someone else doesn't have, or their practice manager or their team know how to work it and navigate it in a better way. I talked about how many people can we count. On an average Monday morning in our practice, there are about 900 phone calls come in. Now, there's absolutely no way that we would have reception staff to deal with 900 phone calls, so some of those will not be seen. That's our sort of dropped demand. Some of those will get through on the phone and get an appointment, and some of them will get through on the phone and be told, I'm sorry, we don't have any more routine capacity. But that's different to perhaps what might happen in other practices. So there is some degree of being able to afford everyone, I suppose, a baseline in terms of what their experience might be like when they hit a general practice. But ultimately the access will be dependent on the number of bodies on the ground in terms of GPs or other MDT teams, and also how their teams are structured. So it can't be a one-size-fits-all. I think there is actually an argument to be made for saying the current funding, the way we're funded, so the Carr-Hill formula that sort of dictates how GP practices are funded, is inherently not fit for purpose either at the moment. So we need to look at how we better fund the services that need to go into general practice. So for example, for every 4 patients that we register in our practice, we get paid for 3 of them because we're not in an area of high deprivation. whereas in Kieran's practice for probably every 6 you get paid for 8 or something like that, because he works in an area of high deprivation. But we actually need to make that funding model even more fit for purpose, so that we're actually meeting the deprivation and the inequality where it needs to be met. So there are lots of things that need to change, but inherently I think what's important is that every single GP practice right across the country is doing the very best that they can with the resources that they currently have. And each will do it ever so slightly differently.
Can I mention, sorry, I'll bring in a second, you mentioned about GPs this week and the electric being off. I want to publicly thank many of the people around this table who has helped us this week to try and get the electric back on. We have practices that have run right through this week with no electric, and even if they did get electric then with no internet, which means they've no phones and no computers. And certainly I can speak for the South in that we've had other practices house people. We had a treatment room of a local practice up the road. They were housing the doctor, and in Portadown they were housing the receptionist from the same practice. So I want to, say very publicly how grateful we are and how hard everybody worked and how the doctors really came together. But also thank anybody here around this table who helped us, and to look for the future for the learning about how we can truly, in a situation like that, prioritise a GP practice to get it back and running again and get us up the priority list with NIE and with Open Reach and stuff like that. But that's something for the future.
That is a huge piece of learning. Because I had people who said, I really need to contact my GP, but I can't, and it's not their fault, they just have no way of doing it.
Are you wanted to come in?
No, you just mentioned about the waiting lists, and it's well versed in terms of where patients have to wait longer and they're getting into difficulty. They will come back in through our door, so that is an impact then on access, full stop. But you're right in terms of if I sit across from a patient and decide you are going to need hospital intervention of some kind, whether that's routine or urgent, when you look at something as simple as an arthritic hip, and I am saying you need a new hip, how long you're going to have to wait for it is a different matter. The impact then, as you say, on your working day, those patients that have a need and it's not likely to be fulfilled anytime soon. The other thing that has crept in, which was never the case, whenever you've been looking after somebody and they're becoming more acutely unwell, and you decide that they need hospital treatment now, as in urgent or emergency care, and we will get an answer to say, you're not sending me to the hospital, are you? That is with all our colleagues in secondary care doing their absolute best and under pressure, and our NIAS colleagues as well. But for a patient who is getting more acutely unwell to say, you're not sending me to the hospital, are you? That is the reality of some of the acute access difficulties we're facing now, where somebody feels that they're frightened
to go.
Yeah, they're frightened to go to the hospital.
What about ambulance access then? Is that a huge issue?
Terrible.
No, it's only really the only ones we would recommend are maybe from the nursing homes or a possible fracture. Everybody else we're saying I live in Armagh and the closest hospital is Craigavon or Daisy Hill. We're saying to people, bundle them into the car, if they're elderly and they've got chest and problems, whatever, you will get there quicker. It used to be the perception that if you got an ambulance you would be prioritised. That is not the case. You will not. You'll spend your time outside of the ambulance through no fault of the ambulance staff or the ED staff. They're working really, really hard. But it's, if you want to get your person seen quicker, it's better to get them however you can to the hospital under your own steam.
There was an email recently, a few weeks ago, about a 24-hour wait for an urgent ambulance. So you visit...
In the Northern Trust?
No, that was across the whole of Northern Ireland.
Yeah, everybody got that.
But just yesterday morning I was in clinic and I had a woman come in early for this really bad chest pain. She was actually quite distressed by it, so I had her on the couch, ECG, a few things, and there was clearly a problem here. I said, we're going to have to send you to any. She says, yes, I woke at 3 a.m. with this. I phoned an ambulance. I've been waiting for 6 hours. She came to me when our doors opened at 9. And I says, I can phone an ambulance too, but it'll be 6 hours for me as well. Probably, have you anyone could take you up? Nobody. She was over from England, isolated. And we decided that the least worst situation was I would write her a letter, put it in an envelope with her ECG, and she would drive herself up to Antrim Hospital. And I phoned the hospital later just to check she had made it. But it's not, anyway, a good situation to be in. And that's just an example. But when we frequently have this difficult conversation with patients who don't even want to go. Those that can get up, they know they're faced with hours and hours and hours on a plastic chair, waiting. And
as well as that, that letter also said that for somebody in a healthcare setting, it could be as long as over 30 hours, which means, am I meant to sit on a Friday afternoon with the patient in my surgery until Sunday morning?
well, you'd be better putting them in your own car than driving them up.
Which I think many of us have done.
Sometimes. But the other thing, it pushes the GP into taking more risks, really, handling stuff in the community that we wouldn't have done 10 years ago, simply because the patient doesn't want to go or won't go, and we're doing our very best to facilitate that, and sometimes acting quite outside of protocol to do it. But it's difficult. It's a stress.
Can I say thank you for being so open with us? I think that we as a committee in this last exchange are seeing the real pressures that GPs are under, and I suppose the toll that it takes on you as someone who is providing care in almost impossible circumstances.
Sometimes
so
we're not
thank
even
you.
providing care, I think, and to hear your thanks is actually really important, and we're really grateful for that. And I think any GP who would potentially be watching this, either live or in the future, will be really grateful for that as well, because you talked about moral injury and right up and down the country, that's what we're saying day and daily. And I think we've all had conversations with colleagues. We've all been in a situation where we found it very difficult. But, the ambulance is one thing. But when you're trying to make a red flag referral for a patient that has got cancer that isn't going to be seen anytime soon, because the red flag rates are beyond 6, 8, 10 weeks. That's before they see someone, before they get the investigation. And, part and parcel of what we do, sometimes we see lots of patients who are not that sick, but sick enough to see us. And then sometimes we see people that we know are really sick. And when you know that you're making a red flag referral, and you know that patient's cancer and their outcome will be much worse because of the waiting list, because of the delay, that really takes its toll, because you can't, sometimes I'm fortunate enough because of where I practice, I can say, can you go private? Or they'll say to me, I'll go private. But if you're working in a community where that's just not an option, those patients get a non-service. They get a service which makes them sicker. But if you're doing that day in and day out in your practice and that's all you see, it's no wonder people are saying,
how often are you? I talked to GPs who told me that they were almost, I don't know how to say it, red flag referrals, if that makes any sense to you.
You say to patients, if you haven't heard, let me know, and invariably they let you know, and then you're back on the phone, or you're trying to put another letter in, which often gets bounced back to say, no, they're already in the system. It's but it's it's really urgent, or it's and red flag creates that degree of sort of difficulty for us. But you think of those patients sitting at home, knowing that I've referred them on a red flag, which they think that the doctor thinks I've got cancer. That's what, or I need to rule out cancer. That's what a red flag means. And if you've been told that you've been referred red flag and you've just got to go home and wait weeks and weeks and weeks, it's just, it's bad for us. But think about the patients. My goodness,
it's terrible. And as well as that, I'm now sitting in my surgery and I'm saying to patients, your red flag is one thing, but the more routine. So you're now 70 and I think you need a knee replacement. Right, how long, doctor, will it be before I see the doctor? Well, to actually see the doctor would be between 3 and 4 years. And then I'll be put on the waiting list. Yes, then you'll be put on the waiting list. And how long could it be then? 6 or 7 years. Well, they're now 80. But if they're 80, are they ever going to get it? And patients say to me, is there anything I can do? Yeah, anything I can do quicker? And, you'll say to them, well, you can go private. And they go, do we have to do it all privately? And you go, well, you can skip the first part of the waiting list by seeing the consultant privately and then revert to NHS. But, even patients who I know cannot afford it are asking me to do that for them, especially in those specialities that have huge long waiting lists. And we're now getting to the stage, the patients ring up and make the appointments themselves and you do the letter. They're coming back to me saying, oh, it's 3 months to wait to be even seen privately.
Yes.
Okay, thank you.
Thank you very much.
Alan Ramsey.
Thanks, Chair. Look, first of all, I want to thank you for your presentation today. I think it's very powerful, probably one of the most powerful and convincing presentations that we've had on here in a long time. I just want to ask, you know, I see your frustration. We share your frustration, I can assure you. You know, whenever we see ideas that you're presenting, whenever we see models of care like MDTs, that the evidence has shown the change that it makes, and we see how the department seems resistant to rolling these MDTs out. It is a deep source of frustration for us on here. I just want to ask indemnity. The last contract, we were very excited last time when we heard Robin Swan telling us of £5 million that was going to be made available, and I know it ended up, it was repurposed, repackaged money within the existing envelope of money, and one very prominent member of this committee called it a sleight of hand. I'll not use those terms, but I'm sure you...
Go on, do it. It's exactly what it was.
Well, I'll not put you under that kind of pressure to ask you if you believe that.
Yeah, we've been promised this time that the offer will be additionality, will be new, and will be outside the current envelope. What we do want to ensure was that the repurposed money from last year is all still there to start with. So that's one thing, and we'll be seeking reassurances on that. The amount we've been offered, we're told, is new. I'm hoping that it is new.
That's good. You answered the question before I even asked it, Francis, because I was asking if it will be new money.
Yes,
It has been stated as new.
It's been stated as it is new money.
Hear.
Yes,
that is good to hear. Can I just ask, just before we conclude today, you know, by the end of this mandate, I know you people don't work on mandates, we do. Worst case scenario, where will general practice be if those asks, national insurance contributions, core funding, indemnity, if they're not delivered, where will general practice be?
one word.
Tell
Closed.
the country today.
Closure. You'll
One
have parts of the population that will not have access to GP services. That is the reality.
And if you think of our 200,000 consultations a week, 10% of the population, versus the 750,000 consultations in ED every year, ED are not going to be able to cope with 200,000 more a week. They just aren't.
I hope the department's listening.
Thank you, Alan. And Colin.
Thank you very much, Chair. If the department's not going to listen to you, there's no point in sitting here giving you false hope. There's going to be no major massive improvements in health service in the next 18 months to 2 years, because if there was, we would be seeing the plans for it, we would be hearing about it, we would be being consulted about it, and it's an absolute flippant disgrace that you're back here again 6 months telling us that things have just the same or marginally worse than they were 6 months ago, which will have been marginally worse than the last time that we met you. And Ursula, we've been talking for years about health service and with others as well, and there is just no pathway where I can see that the situation is getting better for primary care. It just isn't. It's extra pressure, extra workload, less money, and something in there has to give, and there just doesn't seem to be any response from the Minister. We hear about shift left. It seems to be the work that shifts left, but the money doesn't shift with it to be able to help you to do that work, and that just is not possible. So I lay it down here. It's over to the Minister. Come back and tell us that things are going to be different for primary care, and tell us, because we'll get warm words from the Minister, where for about 2/3 of the words that he gives us will be telling us the problem that we've already told him. But what we need to do is we need to hear what the solutions are.
Well, part of the solution, if you look back in history, so we were here last May, and that was when we were relatively optimistic before we realised how this year's contract panned out. I'll not go into any more detail. And we're in a more depressed situation now. But last, I think it's June, there's a monitoring round in June, and 110 million was allocated to health. And then I went and asked the department, I said, none of that has come to general practice. Why not? Because I didn't bid for it.
You know where you are in the priority stakes then. So let's just put it publicly over to the department. It's over to them. Come back and convince us that they're going to do things differently for you to try and help primary care if they're expecting you to do more. But even look at the current workload that you've got. It would take something like the e-prescriptions. It's maybe such a small thing, but that would probably take 1% or 2% of your time off the table, which would allow you to focus what's there. It's a computer system. I remember asking the question and getting a ridiculous answer. It'll take about 10 years to get the IT systems in place.
2032, we were told yesterday.
2032. If that's what it takes, our government, our executive, to be able to try and help you to get a bit of paper from one building to another building, then we have to think about what way we actually can conduct business. Because every bank can do it, every high street organisation do it, schools can do it. I can send an email from here to my team in my office. One is in an office in this building, one is in an office in Newcastle, and I can communicate with them. I'm sure it's not rocket science, and we don't need people over from NASA to be able to sort it out. I'm sure this system that's already taken place in other places. But again, I think it shows the value that the department has for you if they won't even sort that out. I have met and visited GP practices over the summer last year, and in any of the meetings that I went into, and there were 3 of them, on all 3 occasions there was at least one of the doctors that apologised but said, do you mind if I just sign these while we're talking? And they were doing their script, because it was just something that they could do at that stage. But we can't even get that sorted, I think, is a disgrace. But I want to ask this question, because we have had this debate before. We've talked about wanting to retain the staff, to retain GPs, and we've talked about pay, we've talked about conditions, but we are having conversations about duty of candour. Is that something that is being discussed by your members, and what is their particular view on it in a short way? Because I think we need to have the conversations. We need to find solutions for it, because it's something that there is needed, but it seems to be, from what I'm hearing anecdotally, is that people are a bit frightened and a bit scared of it, and I don't think that that's going to help any further if there's another thing that's deposited on you which just makes people go, do you know what, I'm out of here, you can get on with it.
So I suppose I think it's probably first really important that we frame this in, I suppose, the history as to why we're having these conversations, and acknowledge that, you know, harms have been, you know, sort of inflicted on people, some serious and significant harms, and people have suffered. And I think what is important also to point out is that in moving towards creating a framework where duty of candour can actually be a very positive and important part of what we do, and also to recognise that we already have a professional duty of candour, which, as a clinician, every single day of the week when we practice, it is there, it is part of our duty, and it is part of our professionalism. So I think that's an important frame within which to set any conversation around duty of candour, as we are currently debating it in this country. I think the current being open framework is something which our members are considering, which we as a college have considered, and I know colleagues across BMA and beyond are doing so as well. I think the framework in itself sets out perhaps even more than a duty of candour from an organisational perspective, which would, to some degree, sit side by side with our professional duty of candour. Organisationally, that being open framework sets out candour within, or openness within, sort of a routine day-to-day practice, within how you can actually learn from mistakes and learn from errors, and also what do you do when something goes wrong. That's the candour, the duty of candour bit of it. And in and of itself, that framework is actually a very positive move and a positive step, and would bring us in line with other countries across the UK. So England, Scotland, Wales all have a duty of candour. It's all a statutory duty of candour. And to some degree, there is nuances within how that is applied in general practice. So the current being open framework doesn't actually reference general practice here in Northern Ireland, which seems a bit strange. It talks about the larger organisations. But as a smaller organisation, we would have challenge because of the size of general practice, and also how we interact with those larger organisations. So there would need to be some degree of nuance as to how you would enact an organisational duty of candour in the realms of that document. But as a whole, there is a lot of really positive things to be taken from that, because what we really want to do is to encourage a no blame culture, to encourage the ability to learn from mistakes and enact that. And if we could put that into place, I think that would go a long way to reassuring our public about what it is that the system does when something goes wrong. I think the big challenge is if you attach criminal sanctions and individual criminal sanctions to a duty of candour, what would that do? And it is the belief of our members and a large proportion of the medical body is that that actually would do the exact opposite. It would actually create I suppose a culture of fear, a culture of blame, and an inability to continue to be open and to continue to seek ways to make things better. From a general practice perspective, I think there are some very significant things about, well, what would criminal sanctions do? And John's going to perhaps, maybe you've got maybe some examples of what that might look like in our practice and what we would do on a day-to-day basis.
Yeah, we're constantly trying to improve a service, because excellence is not a destination but a journey, and part of that you're doing quality improvement projects in your practice. So you go in and you look at your work, you measure it against the standard, you see if it needs to change. Say for instance a practice is looking at their management of cholesterol issues in their patients. So cholesterol, as you will know, is one of the main risk factors for vascular disease in all its forms. And you do your data trail and you find that there's a lot of patients, their cholesterol register is high, they're on their statin, they're well looked after, but there's a few that aren't. So you go into those notes, there's 10 there, and you find amongst those 10 that aren't in statins, you're going to contact them and offer them. But there is one who had a stroke a few months ago. And you look, and in the notes, well, that high cholesterol was documented 3 years ago, and now we've had a stroke in the interim. And then you look a bit further, and perhaps they've had a visit to the hospital, a diabetic issue, a vascular issue, where it was also noted and not acted on. Where is the duty of candour in that? Was the statin omission itself the chief reason whenever risks are often multifactorial? Was the fact that I'm only one of maybe several clinicians that have a hand in this chart? And then, how much time do I spend digging into that? Where do I find the time to do that? Then do I draw the patient in for a conversation? There are a lot of practical considerations here. I mean, I am open to the duty of candour, to continuous learning, to an open environment where we do that. I, like Ursula, I'm just not convinced that attaching criminal sanctions to that is the best way to achieve it. For one, it would disincline a doctor to do a quality improvement search. Secondly, there's issues at interfaces where we share care, either an MDT within the walls of our clinic or with secondary care colleagues. If you find a deficiency in care and it's between the two of you, that doesn't foster good working relationships. Who reports, who carries the can? So the criminal sanctions element needs to be very carefully thought through for unintended consequences.
Those unintended consequences are obviously workload, like John's maybe discussed, and actually the interactions that we have with patients. So defensive medicine is probably one of the unintended consequences of attaching criminal sanctions to a duty of candour. And I think we can ill afford defensive medicine in this country in terms of over-investigation, over-referral, those kind of things. When I think through a framework like the Being Open framework, we can foster that openness and honesty and learning in a way which doesn't point blame and doesn't attach that degree of, well, if I don't speak up, then I might get criminally investigated. I mean, I think there are lots of challenges here, and I do appreciate that there is a real difficulty in terms of why we're having this conversation and the things that have gone on before, but I think we need to be very careful about those unintended consequences. And you asked very specifically, Colin, about the workforce. If we are trying to recruit and retain and attract people into a clinical workforce right across the health service, and we have a situation whereby our framework differs from other regions because of this additionality around criminal sanctions. It becomes inordinately difficult to attract people into working in the health service at any level because of that degree. I suppose it's just, it would be hanging over you. And really what, as organisations, we need to foster a culture of openness. Without that, is there a risk that we would see a decimation of our workforce? Absolutely. Is there a risk that people would retire early? Absolutely. And I know that doesn't sound good. I mean, I know that doesn't sound like a reason not to bring it in. And actually, we should be thinking about duty of candour in terms of what the benefits that we can get from an organisational duty of candour, not necessarily having the stick to beat. But I do think there is a real risk of those unintended workforce challenges compounding the difficulties that we already face when we know that those organisational duties of candour across the rest of the UK are in place and are being affected. And if we could take that initial step and perhaps reassure some people that that is working, that framework is there and is working without initially attaching those criminal sanctions, then I think that would be a very positive move.
Listen, thank you. I know it's a conversation that will continue. It's important just to get them all out there, and we'll have more of them. But it is something that we have to progress. But I think it's about trying to find something that we can progress that works for everybody, because we don't want to frighten people off. But we do need to meet some other priorities and pressing things as well. But thank you.
Can I just quickly mention your e-prescribing?
Yeah.
E-prescribing is ridiculous that it's taken so long, but it is the system is there in England and Scotland and Wales to do it. It's just a matter of bringing it over, and they switched it on overnight in the Republic of Ireland when COVID came in. Overnight.
We'll take 8 years.
I suppose just before, to finish, I'm very conscious we have another briefing waiting and we're probably nearly an hour over, but I mean, it has been a very, very important and useful discussion, particularly for us. And just on the duty of candour, because obviously we have been very vocal on it. I mean, we said in the debate that we want it to be properly co-designed so that ensures that a lot of those fears, I mean, there's a lot of misinformation out there about what exactly we're trying to do. For me, and I think for the committee, it would be fair to say is it's about protecting patients, but also about protecting staff. And it's about ensuring that there's no cover-up, because that is what has led to the issues, so that people feel safe. To be able to be open and to be honest. I mean, just last week we had a briefing on the cervical smear review. If ever I saw a reason for duty of candour, it was that. I mean, 14 years of nobody speaking up about anything, and look where we are. So we could rhyme off all the examples, but that's not to say everyone's bad and everybody's telling lies. It's absolute. I mean, I've worked in the health service. I would, I can see it from both sides. So that's why we have to find a position that everyone can be comfortable with, but it's getting to the crux, because we're all dealing with families, individuals who have been impacted as well, and I suppose that's kind of where it's coming from. But I think it's a broader discussion, and I hope that will be opened up further in the time ahead. So
I think as clinicians we would welcome that opportunity to have those conversations about what things might look like. And you're absolutely right. I mean, speaking up and talking about error and talking about what needs to be done is really where we need to get to. And there are lots of really good lessons to be learned from elsewhere. I think the huge challenge for us is to sort of that attachment of the criminal sanction. So I don't think anybody here is in any way against an organisational duty of candour. I think that's hugely important. But I think it's about making sure that in enacting that we give it the best opportunity to grow that culture of openness and to grow that culture of being able to do the right thing and to affect the change that is made as a result of learning. And the worry that criminal sanctions would have is that does the exact opposite. But I would really welcome the opportunity for clinicians to get involved in further conversations.
I take everything back to basics when we have any part of these discussions that we have today and we have going forward, is that we're all patients, every one of us in this room, and all our families are patients, and we just want the best for them.
No, absolutely, and that's very clear even from the discussion today. So thank you all again. Thank you for your time and for everything. So appreciate it.
Thank you.
Members, just before we move on to the next briefing, because I am conscious of time, I'm going to just bring forward the SR in case we do have to lose people. So item number 7 is the SO, the Firefighters Pension Schemes and Compensation Scheme Amendment number 2, Regulations Northern Ireland 2024. If it can refer you to tab 7, which includes the clerk's memo at page 48 and the SO at page 50. The main changes brought about by the SO includes to provide early retirement for deferred members, remove the provision for the employer to initiate retirement before normal pension age without early payment reduction, remove the requirement for correspondence relating to an individual's medical appeal to be sent through the department, and to remove the requirement for payments to be made in advance in the compensation scheme. The SR is subject to negative procedure. The committee considered the SL1 at its meeting on the 5th of December 2024 and agreed that it was content with the merits of the policy proposal. The examiner for statutory rules has no issues to raise with respect to this SR. Can I ask members if they're content with the SR? Okay. So can members then agree that the Committee for Health has considered SR 2024-218, the Firefighters Pension Schemes and Compensation Scheme Amendment number 2, Regulations Northern Ireland 2024, and has no objection to the rule? Thank you. Members, I'm going to go back now to our next briefing, and we really are very limited for time, so can I ask members to curtail questions? And I appreciate the last session, because it is something that is a priority for us. It has took a lot longer than we scheduled. So we now have our briefing with the British Association of Social Workers on the review of children's social care services. If I could refer members to the papers at tab 6, which includes a written briefing from the association at page 32. You're all very welcome, and sincerely apologise for the delay, and we appreciate your patience. So I'd like to welcome Professor David Hayes, the chairperson, Elaine Craig, vice chairperson, Caroline Ewart, National Director, and Andy McClenaghan, Public Affairs, Policy and Communications Lead. Just to remind members and witnesses, we have probably a shorter time frame now, so apologies for that. The session will be covered by Hansard. If I could invite you to make some brief opening remarks, and then we'll open up to members for questions. Thank you.
Thank you. Good afternoon, Chair, and thanks for the opportunity to present to the committee today concerning the independent review of children's social care. My colleagues and I will be representing the views of BASWA Northern Ireland members. So BASWA Northern Ireland is part of the British Association of Social Workers, the largest professional body for social workers in the UK. We have 22,000 members employed in frontline management, academic and research positions in all care settings. So the provision of high quality children's social care services is fundamentally important to the functioning of a healthy society. And social workers working in children's services support individuals and families to overcome disadvantage rooted in social, economic, environmental and physical factors. It should be recognised that the children and young people who use social work services are some of the most vulnerable in society, many of whom, because of their age, their stage in life or lack of influence, do not enjoy the same agency taken for granted by other members of our community to speak out and highlight the shortcomings in the services that they receive. The review, led by Professor Ray Jones, was inclusive in its scope and forensic in its detail. It is no exaggeration that it represents a once-in-a-generation opportunity to refocus the way services are delivered to improve outcomes for children and families who use those services, and to address the ever-increasing pressures on the social workers who deliver services. BASWA Northern Ireland fully endorses the aim of the review to shift children's services away from a narrow approach focused primarily on child protection towards one focused on early intervention to improve support for children and families. Early intervention and preventative work, if adequately resourced and prioritised, is key in many instances to stopping problems becoming crises. Supporting parents to care well for their children often leads to better outcomes for children and is less costly, particularly where it prevents children becoming looked after by social work services. To move from the current child protection focused model, services must be resourced, structured and staffed in a manner which enables social workers to spend more time in direct engagement with children, with parents, with families, understanding their needs and providing support which addresses the challenges that they face. We need to see improved funding for services in both the statutory and voluntary sectors, and regional consistency in how services are delivered across Northern Ireland. Furthermore, it's essential that we follow a human rights informed approach in pursuing a reset and refocus in children's services. Basel Northern Ireland fully supports Professor Jones' recommendation that there should be further development of skills mixed within children and families' frontline teams and services. Additional support staff are badly needed to free social workers up to perform the highly skilled roles they are trained to deliver. But while that diversification of skills would be beneficial in supporting social service delivery, it must not be regarded as a cost-saving way to replace social work staff. In addition, it is essential that bureaucratic processes are streamlined to free up social workers to spend a majority of their time, as I've said, in direct contact with the children and families who they are there to support. High quality record keeping is vital to good social work practice, but all too often paperwork constrains rather than supports social workers in their practice. It is vital that the Department of Health, in implementing the independent review, delivers meaningful change to reduce the bureaucratic burden on social workers in children's services. Review Recommendation 3 states that action needs to be taken to address the children's social care workforce crisis, and more than a year and a half on from the publication of the review report, unfortunately the workforce crisis has not abated at all. There is a need for investment in social work recruitment, social work education, professional development and retention initiatives. The social work workforce, which is predominantly female, also require a more family-friendly approach with provisions for greater flexibility for childcare, other caring considerations and part-time opportunities. There's an urgent need to tackle poor working conditions and the unfeasibly high workloads of social workers, along with improved training for social work managers to ensure staff are supported. As with many areas of social work, demand is growing across children's services, and it's of paramount importance that safe staffing standards are implemented for the profession. This is needed to ensure services are provided in a manner that upholds the best interests of the individuals and families who use them, and those of the social workers who deliver them. For a number of years, the high rate of vacancies has led to huge pressures on social work staff, and while the recently reported reduction in the social work vacancy rate to 3.3% is welcome, it actually doesn't represent the situation in some social work teams, particularly in the area of child protection. The reported vacancy rate is at odds with the figures shared with Basel Northern Ireland by directors of children's services, who explain that Gateway, Family Intervention and Looked After Children's teams continue to experience stubbornly high vacancy levels of up to 40%. The figures published by the Department of Health do not convey the whole picture. They cover only vacant posts which are actively being recruited to, and fail to take account of posts that are on staff due to long-term sick leave and maternity leave. It must be recognised, however, that in addition to the requirement for safe staffing models to address the current pressures facing the profession, Basel Northern Ireland anticipates the need for hundreds of additional social workers to provide services associated with the implementation of the Adoption and Children Act, the rollout of the forthcoming Adult Protection Bill, and the continued expansion of primary care multidisciplinary teams. To draw into focus the mismatch between demand for services and provision for social work training, while there's been an 8% increase in social work training places since 2011, there's been a 67% increase in the number of children in care over the same period. We now have 4,185 children in care as of December 2024, the highest ever on record. To ensure transformation is delivered, children's services must receive much greater focus within the arenas of policy making and service delivery. While it isn't a surprise, it is deeply concerning that the review found that directors of services, children's services, only spend approximately 30% of their time focused on their children's social care services. A combination of factors, including the pressures in the health service, the ever-increasing demand for children's social care, the ongoing social work workforce crisis, and factors undermining focused and effective strategic leadership for social care services, led Basel Northern Ireland to fully endorse Professor Jones' view that statutory children and families social care services need to be located within an organisation where that is the primary focus of the organisation. The Association agrees with Recommendation 38 calling for the introduction of a region-wide children and families arm's-length body, which includes the current Health and Social Care Trust Children's Social Care Services, along with other allied services and professions closely related to children's social care. This is the model referred to in the review as Option 5 or the ALB+, Alongside Children's Social Care Services, the ALB Plus model includes the Education Welfare Service, the Youth Justice Agency and the Youth Service. And finally, I want to stress that BASMA Northern Ireland Support Review Recommendation number 29 do not allow the privatisation of children, of the care of children. Children in the care of the state deserve the best standard of support available. Privatisation and profit maximisation has been shown to drive down standards, not raise them, as is unfortunately demonstrated by the scenario in England, where privatisation has led to the proliferation of housing children in unregulated placements, a wholly unacceptable scenario which must be avoided via the rejection of any move towards the privatisation of care of children in Northern Ireland. So, colleagues, thank you for your attention, and my colleagues and I now welcome your questions.
The Deputy Chair is just going to come in.
Sorry about that. Thanks for that presentation. Sorry, just coming in off mute there. Nuala, I think you had the first question there.
Okay, thank you. Thank you very much for coming today. This is one of the areas of priority for this committee. You know, we have taken to getting quarterly reports from the department on the implementation of Ray Jones in particular. I think it's really important that Children's Social Services is getting a highlight across Northern Ireland. Now it is long overdue, and we recognise the impact that has then on social workers. So we wanted to really reiterate from the start that this is about us working with the workforce to ensure that we have the right practice, the right safe staffing for better outcomes for children, so that we can do that together and to hold the department to account where we need to. My first question is around the issue of workforce. The Minister answered in the Chamber just this week regarding the placements and the training, and all of the new students took up placements. Majority of them were in children's services, but one of the issues is we hear about vacancies, and they take all the vacancies, but that's not actually all what's needed. So there's posts that you said there that are unfilled posts, but my understanding is then that's you have unfilled posts, vacancies, but you also have what's actually needed. So can you differentiate between those, and just can we hear a bit more where BASWA is with regards to like what is actually needed when it comes to social services, in particular children and young people?
In terms of staffing levels,
yeah,
or
staffing levels.
Well, that's a good question.
What do safe staffing levels look like? Yeah.
I'll go ahead.
Yeah.
No, it's very, very hard to determine what safe staffing levels look like at the moment, because we don't know what the vacancy rate really is. So I'll take through this. 3.3% is the current vacancy rate as reported by the Department of Health. I think that is from September 2024. That peaked at 11.2% in December 2022. So you'd say any reduction in the vacancy rate, that's to be welcome. And I would say if you were hearing a vacancy rate of 3.3%, you'd probably say that's quite healthy. That does not represent the picture on the ground. As Davy said in the introduction, we're hearing about vacancy rates of up to 40% in various children's service teams. So the situation is we have social work workforce across Northern Ireland, 6,776 registered social workers at present. The bulk of those social workers work in HSC. From the workforce census last March, 4,824. Across the whole profession, the profession is 85% female. You have a large number of maternity posts. Maternity posts that will be unstaffed due to maternity leave. As with any workforce, there will be posts that will be unstaffed because of long-term sickness. Our understanding as BASWA is that none of those vacant, let's call those unfilled posts. None of those unfilled posts are represented in the headline vacancy rate. It's very, very hard for the department to do workforce planning if they don't know how many posts are unfilled. We met with the Minister on Tuesday and raised this with them. I told him at the time it doesn't make any difference to a child who isn't receiving the support they need whether the social worker isn't there because the post is vacant, as the department would regard it. A vacant post, as the department regards it, is if it's been recruited to, actively being recruited to. It makes no difference to the child if that post is vacant and the department's recruiting to it, or it's vacant because there is a social worker who's off on long-term sick, or it's not been filled because of a maternity leave. that child's not receiving the service they need. So we need a clear picture. I would love to be able to tell you what that is. We don't know. We know that SPPG, or we believe that SPPG holds stats on what we would call unstaffed or unfilled posts. And what we really, really need is a sort of composite picture, which is based on what the department knows about the vacant posts as they report them and what is an unstaffed post. We can't workforce plan without knowing that. Other things about workforce planning, it's very, very hard to determine numbers of social workers we need until we've also addressed issues around bureaucracy, which we might want to talk about later. Social workers report spending an awful lot of time filling out paperwork rather than time spent face-to-face with service users. And until you've addressed some of those bureaucratic issues as well, again, it's very, very hard to say this is how many social workers we need. Do you want to talk about...
I was just going to say as well that, I mean, we can talk about statistics and whether the vacancy is 40%. I think what really strikes you is last year I spent some time with social workers in one trust doing a piece of work about their daily experiences in practice. And what I encountered in some offices were situations where I was given a list of teams and team leaders and who to contact. And what you found in some offices was 2 teams had been amalgamated and they were covering the work of 2 teams because each had 3 vacancies. And that might have been one that was recognised as a vacancy and somebody in maternity leave and a couple of people out in long-term sick leave. So those people are trying to cover double the work. And if you ask them what would improve their situation, it would say, well, if we had a full workload, a full workforce, but actually +2 in every team. Okay, so I think, whilst it's difficult to say how many social workers do we actually need, I think we do need to start by thinking about how many vacancies have we got and what work is that leaving behind.
And I think that's very important to highlight, because how can the department actually make a workforce plan or create safe staffing is if it's not actually being open regarding what isn't there. So we'll certainly follow that up again as a committee. And one of the statistics that was stark to me whenever I was reading your briefing and also answers from the Minister and the questions I had submitted was the number of unallocated cases. I wonder if you might be able to actually explain what it means if you're part of, if in particular I'm thinking about the Gateway team, because that to me frightened me, because I'm thinking what Gateway is, that's the first emergency we need interaction with social services. What does it mean to be unallocated, because the numbers are quite high?
You are quite high, Nuala, and they vary across the region. So some trusts will have very high numbers of unallocated cases. What an unallocated case is, effectively that. So a referral comes in, the team leader will screen all the referrals and will kind of assess levels of risk. And if there's information that this is a very high risk case, it will be allocated. So cases that don't meet that threshold as yet are placed on an unallocated list, which means that the team leader essentially holds responsibility for each of those cases. And that could be, in some areas you might only have 30 or 40, in other areas you might have 200 cases waiting that a team leader has to spend time managing. And I think it's a bit of a misnomer to say that those cases aren't allocated. They don't have a dedicated worker, so they're not given to a social worker who will go out, do an assessment and provide a service. But what tends to happen is that the team leader essentially has to keep an eye on all of those cases, and as the situation changes, there might be a crisis that develops, they might then get allocated, or actually you might just find that the duty social worker is allocated to that case for a day. So it's about managing the level of risk on an ongoing basis, and really, I mean, it's a huge added pressure for teams and for team leaders to have to carry that burden and try and manage that risk. And I suppose it's, one of the reasons we're so supportive of the shift in a focus is that I think what has happened across our services is that we've become a child protection focused service. You talked about it, Davy, in your opening brief, which means that the principles of the Children's Order were around one of the P's that we all learned about as social workers was prevention, and we should be providing preventative services at a point where children need them, which is actually to meet families in their communities and provide support and care that people need, that prevent people slipping further into crisis. Unfortunately, because our social workers are delivering an excellent service out there, and our teams are working really, really hard to deliver that. Unfortunately, they're only able to deliver that to people who are in the most utmost of need. So what's happening is that you're seeing this funneling of risk. So high risk situations are getting through because they have to get through, and everyone else just doesn't simply get a service.
Yeah, I was going to say, I don't think we're supposed to use the term unallocated cases anymore. It's a waiting list. It's a waiting list.
So there's much debate, isn't there, Davey?
Much debate,
I mean, having another waiting list doesn't necessarily make it better.
Yeah, it sounds slightly better, but I mean, I think that the issue is that the staff we have can only deal with so much, and it's the prioritisation of high-risk cases. Unfortunately, if you have cases that are on a waiting list, what tends to get them off a waiting list is something happens to the child in that family. So we're dealing with children where harm has already occurred and trying to prevent it, not trying to prevent it happening in the first place. And I think that's a real indictment of our society, that we cannot provide preventative service.
And it's not shocking at all, because we hear in other areas of healthcare where we cannot put the focus on preventative measures and people end up in hospital where they don't need to. Look, I could ask loads of questions, but I can engage offline. But my last is just regarding the work streams. Do you have any feedback regarding engagement with the work streams? It's one of the words that we hear quite a lot from the department when they're at committee, is about ongoing work in the work streams. What is BASWA's engagement like? I mean, how effective are they at actually seeing the change with regards to implementation of the recommendations?
I mean, I think there's our engagement with the work streams, I suppose, in fairness, we're engaged with 2 of the work streams. So that means there's 8 work streams happening. We're about to get involved with another work stream around the social care workforce. But I suppose in essence, I mean, I have to be honest, one of the work streams is around legislation, and that has been progressing, I think, through with no particular issues. The other work stream that we're involved in is the reducing bureaucracy work stream, and I was very keen to be on that, because we have been campaigning around reducing unnecessary bureaucracy, and it is unnecessary. We're not saying you can strip all bureaucracy out of social work. Far from it. It's a cornerstone of good professional, practice to have good, competent records. But so I've only been to one meeting, and I think there was a bit of a slip up. I was meant to be invited onto that meeting a year ago, and I was sort of emailing asking what's happening, is this group not meeting? And I only got the invite through a month ago. So that was a source of disappointment. A lot of bureaucracy to get onto the bureaucracy work stream. But I have to say, having gone to one meeting, I mean, I think it's being led, and I think there's a real interest in taking forward the aims of reducing unnecessary bureaucracy, and I'm keen to work with that group going forward. I suppose our sense of the groups overall is it's a huge agenda, and I'm not particularly clear on what new stuff is coming forward. I think there's a lot of work that's being presented in those forums that is work that's been around for a while. And that was our worry and really feedback, that when we have them up here, and it's very frustrating to have you confirm that for us. Yeah, but look, thank you very much.
Okay, thank you, and apologies, I had to step out there. I was unavoidable, but I have just a couple of questions, and I have been speaking with some of you before anyway, so I don't want to go over old ground, and apologies if this has already been covered in the time that I was out. But I suppose, I mean, the workforce issue is the biggest factor, and this is right across the health service, particularly, I suppose, my own interest in social care and social work. I mean, when we raise this with the department, we are told all this work that's happening to address it. Are you seeing the impact of that? You know, can you say that, yes, things are, maybe if it's slowly, things are improving, things are happening that we think will make a change? Or are you still, I hope I'm not putting anybody in a position, but it's important for us to hear that, because...
Yeah, I mean, I think I said in our view, the workforce crisis has not abated. It's still ongoing. And I'm not saying that people aren't doing things to try, but I'm not seeing an immediate impact.
And I suppose, yes, and that's kind of the point I've picked up. I suppose maybe then, from what the work you've seen, and maybe some of it hasn't landed yet, but does it give hope that things will change for the better? Or do you think that there's things that, from your perspective, I mean, I always say this to people, if I had RTN in here or whoever it is, you have the solutions, you know, you're at the cold face of it. So are there things that you think that maybe have been raised? Nuala's outlined around the work streams, and I suppose even that issue around the engagement with that. I mean, is there more that could be done that maybe hasn't been, I don't want to say they're not being listened to. I just mean that there's things that maybe you've put forward that haven't been picked up, but you think that still should be looked at, if that makes sense.
I think we'd want to give credit where credit's due, and I think in this regard the department are working really hard. So in terms of the safe staffing legislation that's going through, and we would encourage you, I think, to support that as a committee, that will actually hope to address some of the key issues. I think as well there's a lot of work happening, and we are hopeful that that will lead to a change. We're not seeing it yet, but the department are leading on work which is trying to look at caseload sizes, and they're planning to bring a paper, a guidance paper. They hope to have that published by March of this year. As BASWA, we've been very involved in that and are very pleased to be part of that work. And I think we do hope that will see, anything that can kind of quantify that we know that social workers are far too busy. We know that they are dealing with too much work. So what the department are trying to do is get to a place where we can have a range of cases. For example, Setting the Bar report, which was a report published 2022 in Scotland, established there was lots of work done in terms of looking at what a social worker caseload should look like and what was deemed as safe and unsafe. They came back with figures based on lots of analysis around 15 children is a safe caseload for a social worker to carry. We know that is our social workers in Northern Ireland are working way above that. At the moment, we don't count children, we count cases, and the social workers here are working with above and beyond 15 cases, which may have 2, 3, 4, 5, 6, 7 children involved in that case. But in fairness to the department, I think they commissioned a piece of work with Professor Paula McFadden and Professor Mary McColgan from the Ulster University, who have tried to take an evidence-informed approach to say, this is what our combined knowledge will tell us what is a safe and effective caseload for a social worker to have. We're hopeful, I think, that report, and there's been a constant source of debate between us and groups where we're working, where we think they need to come up with a number, and there's some debate around whether they'll be able to come up with a number. And there's lots of issues for that in terms of you need to have a number that's flexible, you need to be able to, we all have examples of our practice where one case took over our entire week, and you need to be able to factor that in. But I think until we have that sense of what actually a safe and acceptable caseload is, we then can't know how many social workers we need to have in the system to make it work.
And I think our conversation with the Minister on Tuesday, if we come up with that, that's great. If we have some sort of idea of what's a safe, but we may not be able to implement it if we don't have enough. So the example I gave of 2 teams being amalgamated.
Yeah, no, and I appreciate, I think, and I wasn't trying to be critical of the department, I suppose, from the outset. It's just to get an understanding, because we speak with trade unions and others as well, so we're just trying to get a picture of what is actually happening, and is it making the impact. And it is good to hear that there is, there is hope, essentially. So it's just my last point is particularly around the social care review. We're almost, I think, 2 years on. Yeah. From Professor Ray Jones published his review. As a committee, it's a priority, as I'm sure you've heard, and we're getting regular updates and briefings on that to ensure that it is moving at pace. For me, the biggest thing is, and you've said it in your opening remarks, these are children. Absolutely. And while the longer it takes us to implement, these kids are still waiting, and families, and prevention is always better than cure. So while we wait for things to be implemented, everything else is getting worse, essentially. And as you said, David, it's only those children that when they're at harm. So, we're all well aware of the very high profile cases that have happened over the years where things have went really badly wrong. Do you feel at the minute that that's a potential, given the circumstances that social workers are operating in? Families can't get access to the support when they need it, because the vast majority of cases are where if they had family intervention at the right time, they'd never be on a child protection register. And I suppose, would you say then we need to move quicker? is where we.
Yeah, well, unfortunately, the chance of that type of tragedy happening is always there.
Yeah.
And I think be heightened in a situation where you have cases sitting on waiting lists where you're not able to provide preventative services. So yes, I mean, I think we just pray that doesn't happen, but it's a very real possibility. Yeah.
And I think, our session was previous to this when we had the GPs and we talked a lot about moral injury, and I think that's also very relatable to social workers who are, she said, just hoping that things don't go badly wrong until they get to that child or that family. So thank you for that. Danny?
Thank you, Chair. I know we're pushed for time, so I'll try and be brief. Obviously, we've been very well briefed just about the pressures within the system. The Minister announced 13 million for children's respite services, and respite services are something that we would all get contacted about quite regularly, I would imagine. Certainly, I'm aware of quite desperate shortages in my own area. Has Basra noticed an impact from this inability to access respite care, and just have we seen any difference on the 13 million that has been announced?
In terms of the money that's been announced, we haven't actually had much contact. We're not really aware of what the impact of that has been. I'm wondering, was that additional new money, or was it money that was provided? It was new money.
I think so, yeah.
So we haven't been contacted about that. I mean, there's issues around the children's system within looked after children and children who are disabled. And I think that is an issue. It doesn't really answer your question, unfortunately, but the issue of looking at children who use respite services as looked after children is an area that we have campaigned on and have said that children shouldn't be considered as a looked after child because they access one night's respite per year. And I think we've had a lot of support with that issue. But it maybe doesn't answer your question. Sorry, Danny.
No, you're fine. I'll go back myself. Thank you. Sorry, it maybe just isn't as relevant to this session. And just one last question. We obviously heard a lot about the arm's length body. What difference would this make it look like on the ground? What would be the big changes that we would expect to see?
I mean, I think fundamentally the changes that we'd see, I mean, we've been very open in terms of our support for it and the reasons for that. I think having all of children's services alongside justice and education would be really transformative. At the moment, we're an integrated health and social care trusts, and I think we're all quite wedded to that notion that we're integrated, and people are reluctant to kind of consider what that might mean. What it does mean is that children's social care is housed in a health system which is not really set up to look at what their needs are. Most children don't interact with social work services because of their health needs. Some of them might, but that's not the primary reason. So it'll be for issues like poverty, housing, a whole wide variety. And I suppose our support for the argument has been that to remove that health focus, as we know, and as you know, you've heard today from the GPs and the BMA, the health system is a massive system that needs lots of resource and lots of support. We all often find, and it's not to be critical, but actually we often find that second to that is social work and it's social care and adult social care within that world. When we're looking at children's social care in particular, to have a body that its focus is actually on children and delivering really good family prevention type services rather than the system that we have that fights within the health system to get access, we think would be truly transformative in terms of its approach.
Yeah, if it's okay, I can just give an example.
Yes,
a long time ago, I was a social worker, and I can remember this is a long-standing issue, making a case for a child who needed a very specialist placement, would have had to go to England to get that service, and basically being told the cost of that would pay for 5 kidney transplants every year. So no, you can't have it. So we should not have a system where children are in competition with acute health care and their needs are not met as a result of that. So I think just having that, this would be an organisation focused on children's services and resourced and not in competition with acute health care. I think would make a huge difference.
Yeah. And arguably, if I could come in there, Chair, arguably if we did this right, then there would be less pressure on health.
Yeah.
Absolutely.
And education and communities. And,
Thank you very much for that, Chair. I'm finished. Thank you.
Thank you, Danny. And Diane.
Just a couple of very quick questions. The Minister rolls out figures of the number of additional social workers that have been in post for the last number of years, and off the top of my head I can't remember them, sorry, but they are quite significant, the number of. One of the things when I talk to people who are in social work is that they indicate that many of those social workers who are very young and just newly trained are left with incredibly difficult, complex cases to work with. What's your view on that, and how can we help the social work force in that situation? And what is there around those young social workers to help them through those varied, because some of it, some of the stories I've heard, they are very, very complex and very difficult, and I think that sometimes young people in social work are left to deal with very difficult situations.
David, do you want to start that?
Yes, they are, and I mean, I think all these things are interlinked about the workforce crisis. You have people qualifying from university and going into teams.
Yeah.
I mean, I've heard of some teams where the entire team is made up of newly qualified social workers with a team leader who's experienced. So they are supposed to be doing an assessed year in employment, which is supported. They're supposed to have a reduced caseload, increased supervision, mentoring. In many cases, that isn't possible. They're just sucked into dealing with the day-to-day crisis. So I think it's about stabilising the workforce, making sure we retain people in the workforce so we can bring new people in but support them properly. My daughter is currently doing the social work training programme, so it does make me a bit nervous about what she's going to encounter when she goes into practice. But I think it is all interrelated. We need to stabilise the workforce, retain people in practice, so we can bring new people in, and we need more training places. So I think I've been teaching at Queen's since the degree was introduced in 2004. Queen's used to take 130 students a year. In 2011 it was cut to 112. So I think over the past 14 years the number of training places has increased by only 8%. And that most of that increase has been in the last couple of years. So the Open University were brought on stream, and last year I think there were 40 additional places altogether, 15 at Queen's, which the Department of Health came forward with. I have to say at the very last minute, we're very grateful that there were additional places, but no guarantee that would be on an ongoing basis. So I think we really need to think about how many social workers do we need to train, and start increasing those places so we can meet the need out in the workforce.
I also get contacted by parents who are very worried that they have no allocated social worker for their young adult with disabilities. What's the advice to those people?
The advice is to speak to the team leader and to try and make sure they're aware of the issues. I mean, we know that unfortunately, because of the crisis within social work, there are a number of young adults and children who don't have access to a social worker. There's a list kept. I think the last we had about 400 children who didn't have access to a social worker. There simply wasn't anyone to allocate to that case, and it's unacceptable. It really is. I mean, it shouldn't be happening. Everyone, and those now were children in care, so those were looked after children who are brought into the care system, who should have access to a social worker at the basic minimum level of right. So they need to flag that up, and they need to be speaking to the team leader, and if that doesn't sort the issue for them, they need to raise a complaint further. And it probably will end up on a list of someone who, who doesn't get access to a social worker, but at least they're keeping a record of it. And as soon as someone becomes available, they'll hopefully be able to allocate that. But use your power and authority to be able to say it's not okay. It shouldn't be the case. We shouldn't accept that. That's how things happen.
We do make representation all the time about individual families who come to me, and it's a bit like making representation for the person who needs a new hip or a knee.
I know.
It's back to the list. It's really difficult, but that sometimes there is a crisis that could become a very difficult crisis if there isn't sorted out. Just and my last question is, you said that in Scotland that it said that 15 children was a safe workload per social worker. Do we have any sense of what the average workload is in Northern Ireland?
We kind of, I think anecdotally we know that actually that's work that the department are working on at this stage. There's been a lot of groups kind of trying to analyse what would be considered a complex case, a moderate case and a low level case to try and give some sense of that. But we know that in and around 20 families, now that's families, so that they may have multiple children. Yeah. So in and around 20 within children's services wouldn't be unusual. Some people will have more than that, and certainly probably people who are a little more experienced will be carrying higher caseloads than that.
Chair, the social workers I worked with last year would have been dealing with between 15 and 20 cases, they called them, but that was families, so not children. And when I was a social worker, I remember working with a family who had 12 children. So if you think of it,
and we all remember. I mean, back when we worked as social workers, I mean, there was situations where one of the things we talk about as well is skills mix. And trying to bring in other staff who can help support. I mean, we were sharing earlier that I remember I had a situation where a baby was removed shortly after birth into care and was placed in a foster placement, which was about 40 miles away from where the mother lived. I, as the social worker, was directed to provide daily transport to the child, so I had to drive.
It still happens.
It still happens.
Yeah.
It still happens, and it shouldn't be happening. If the social worker needs to be involved in supervising contact, that's one thing. But actually, if you're just having to drive the child from one place to another, we should be able to employ contact workers, family support workers, social work assistants, call them what you will, but we should be able to provide...
Does the family hubs not give you any relief in relation to that?
In some places, but they're not. I think that's
they're
one
not
of the
universal,
issues. They're not universal.
I know. Yeah.
They're not. And some trusts do have contact workers, and where they have contact workers, that works very well. Other trusts don't have access to that. So that's one of the other issues in terms of Ray Jones's review, is trying to, tease out that... that what am I trying to say? Postcode lottery. Yeah. Postcode lottery is the term I was after, sorry.
We talk a lot about that here.
Yes.
So I'm trying to determine what is a social work task and what isn't. Yeah. So social workers are doing things like making payments to carers, all these sorts of administrative tasks that really we need to think about. Yeah. There should be a team clerk or a family support worker or somebody else who's doing that sort of stuff. And you should be out with families and with children.
And we have evidence for that, Chair. During the Jones Review, we worked with the Northern Ireland Social Care Council to survey social workers about the skills that they considered central to social work and also the tasks that they considered central to social work. We asked them, what tasks do you spend most of your time on, single tasks or multiple tasks, and what tasks do you think could be undertaken by a non-social worker? So 24% of social workers said that facilitating family contact was one of the tasks they spend most of their time on. 70% of those social workers felt that task could be undertaken by a non-social worker. The bureaucracy issue, 64% considered bureaucracy the task they spend most of their time on, or one of many tasks they spend most of their time on, and 49% felt that it could be undertaken by a non-social worker. So there's a huge amount of potential to diversify skills mix. Again, though, it's about having the right people in place to provide that support. It's always about training, it's always about having the right staff, and that needs to be taken into consideration in workforce planning. It's not just what the social workforce needs in terms of social workers, it's what we need in terms of support staff. And just to reiterate what David said in the introduction, it cannot be seen as a way of doing social work on the cheap. It has to be listening to social workers and saying, what do you need to support, rather than we determine you need X, Y and Z, so we need fewer social workers. That it can't be like that. It needs to be looking at what social workers need to do their jobs properly.
And there's lots of pieces of legislation, Chair, that are coming down the line that we're acutely aware will put even more pressure on the system. You know, there's the Adult Protection Bill, there's ongoing, mental capacity legislation. What are the other ones we have, Andy? And MDTs, the multidisciplinary teams, which we know are a really good model, and we know that the GPs who have those are feeling real benefit from the support of those. But actually, they're really crippling social work teams, childcare teams. Because what we've seen over the last number of years is that the people who are tending to apply for those are children's social workers. So they're leaving one area, they're moving into a much more supported, much more streamlined in terms of bureaucracy, able to do the role that they came into the job to do, and they're seeing that as a very fulfilling opportunity, which further depletes the workforce we have in children's social work.
I think we have 312 GP practices in Northern Ireland. That's if you had one social worker per practice, that's roughly 5% of the workforce. You've also got to bear in mind that the mental health practitioner role in the MDTs, many of those roles can be filled by mental health social workers. So it is a big drain that needs to be factored in.
Yeah, absolutely. Colin?
Oh yeah, it was just a quick point on that, because I think is the figure the Commission places at the minute from the department is 325 per year. So I'm sure some analysis has been done somewhere that was the number that's required, and I'm sure it's way short of what it needs to be. Yeah. But yet, whenever the Minister answered the question the other day in the House, he got really excited about 221 new qualified social workers in 1 year and 225 in another, which when you add it together over 2 years leaves us 225 social workers short. Would that figure be correct? Because if it is, I wouldn't share his excitement that he got into quite a fluster of excitement. He actually repeated himself at one stage. He was so excited about how many new social workers were being qualified. But if it's well short of their own, there's 325. If that's the number of places you would expect, that's in and around what will qualify. But if 100 less are actually taking up posts every year,
the 325 probably only applies to this year. That would take into account the 40 additional places that we were given and the OU. So before that, it's been more like 275, I think. And the point about at Queen's, we lost 18 places per year back in 2011. Yeah. So there's what, another 250 odd social work staff we could have qualified if those places been retained. And I'm not sure the 325 figure is what they think is necessary to keep. It just happened that way, that we were offered additional places. I think there was a notional 60 additional places per year were needed just to keep
to keep up with current demand.
And even then, I've heard people saying that they did believe that was an underestimate. So I'm not sure we're there yet. With the training places has not been addressed significant or satisfactory. We got additional places this year, but no guarantee that would happen next year again.
I think maybe given the sort of confusion that there is around it, might be good to seek clarity. Maybe we could write to the department and basically ask them, what is your formula? How did you work it out? How do you see it going forward? Tell us what you think the formula will deliver in the next 10 years, because if we're going to workforce plan, we've got to start looking a wee bit further than this year and maybe a guess at next year. We need to know longer than that. And I take the point that you've made that the Adult Protection Bill, I think even it in its own right, there's suggestions that it could take 60, 70 social workers just to fulfil the obligations that there are in that. And also the bit about MDTs, because whilst I'm not going to say that the MDT work is easy, I don't mean it in that way, but being in a nice health centre 9 to 5 Monday to Friday, getting your holidays and actually able to get
getting a lunch break,
that sort of work compared to what maybe some are facing in the childcare teams, where it seems to be crisis after crisis. I think we do need to get some heads up on that. So thank you.
Can I just ask one thing? The 40 additional you're talking about for last year, is that going to be recurring every year?
No, there was no
so that was just a one-off?
That was a one-off. Okay. It may be recurring. Could I make another point here just about the additional places? Those 30 of those 40 places were to the 2 universities, and they were restricted to, we have a 2-year route for people who have a relevant degree, and they were restricted to that route. And the thinking seemed to be, well, they'll qualify quicker.
Yeah.
They'll qualify in 2 years rather than 3 years. And I personally find that a bit abhorrent. I think access to social work education needs to be fair and equitable, and we need people from a range of different people who don't have a degree but who have maybe lots of practical experience in social care. So I think we need to be careful that additional places aren't driven down a particular route because we think that's a quick and easy fix.
I think that's
absolutely.
Chair, sorry, just to mention as well, Colin, just you probably factor this into your thinking. It's not a 325 net gain, obviously, because you've got your retirement rate. So it's to factor that in.
It's just to plug a hole every year.
Yeah.
And those places, those 40 additional places, we were told have been predicated on that they will be delivered to the multidisciplinary teams. So it's, that they're going to be... Now, I don't know if there's any kind of way that they can enforce those people, but that's the reason that we got the additional 40 places, was to support the multidisciplinary teams rollout.
Absolutely. Well, thank you. And I suppose just on the point of the training opportunities, and I actually had spoken to even Open University, I think there's lots of things we do. I mean, even you talk about social work assistants, like giving them a pathway, working parents who maybe can't afford to give up their job to study. And as someone that did the 2-year course, and Davey, I think you taught me, and I just realised that halfway through the meeting.
Sorry for whatever it is.
Well, I've ended up here, so I don't know. But no, and I mean, I'm a huge advocate of it as well. I got an opportunity last minute because I didn't get onto it because it was limited places, but completely agree with your point around giving people opportunities who haven't a degree, because I was one of those people that didn't get on in the first time, went away to Liverpool, did another degree, went out then worked in a care home, and then went back and was delighted to be able to do it. So it's about now recognising the change in nature of our society, and that people at different stages, it's not just somebody at 18 coming out of school that wants to go in and do a degree in social work. It's maybe somebody who's had their family and now feels that they're in a position. So, and that will lead to a more diverse, more experienced workforce, which will help to tackle all of the issues I think that we've outlined. So look, thank you all again. Really apologise for the delay, but we do really appreciate it, and I think this conversation will remain ongoing, particularly given our priority in terms of the review. So thanks very much.
Thank you all.
Thank you everybody.
Okay, members, given the time and we're losing quorum here, I'm going to propose that we defer some items to next week, if you're happy enough with that. I just had one that I wanted to raise because I do think it's more urgent, and it came in our table papers today. It's in relation to the SWA review. I mean, I think from hearing from the local area, there's quite a lot of concern in relation to this, and I was going to propose that we invite RQIA, PHA and the department to brief the committee at the earliest possible stage in relation to that, because I do think it's a very critical issue. So if members are happy enough with that.
I'm happy enough with that, but also the Northern Trust are about to make exactly the same decision in relation to emergency surgery as well. So just to bear in mind that this is going across a lot of the trusts. We can't have them in because they haven't made the decision, obviously.
No,
but some of the stuff that the RQIA, I actually in our response to Northern Trust consultation around ambulance times and so on, said, like, how can you do this with, the poor cover in such a huge rural area? So just to be aware that lots of other...
just maybe the trust as well, I should have mentioned it, but don't make a reference to the trust as well. I think it's the Western Trust. Yeah, sorry, Danny, go on ahead.
No, sorry, I would agree with that. I just had another point just relating to our first briefing, but if you want to go on ahead. Okay,
I was just going to then, Danny, the briefings, the oral brief or the written briefings on dental services reform and Encompass, if I'm happy to defer them to next week, so when we've more members, and the remaining correspondence, I'll be happy enough to defer that to next week, just so we can make sure it's covered properly. Did you want to come in on that issue now, Danny?
Yeah, Chair, just with our first briefing today, I just wanted to suggest that we write to the department and ask just about the current state of the practitioner health programme, and also ask them just if we could get those figures for the costs of the trust-run GP practices. I think that would be very useful for us to see them and to see the difference that it actually costs to run a GP service compared to what the services are telling us on the ground.
Yeah, no, absolutely. And I think given that some of those are my constituency and it's locums running them, I can imagine what the costs are. Okay, thank you for that, Danny. The forward work programme then, I'll just very quickly it's page 215 of your pack, just to note that the committee has agreed to carry out a series of visits throughout February and into March. Next Wednesday, the 5th of February, the committee is due to visit Foyle Hospice at 2 p.m. For those members that haven't, can you please confirm your attendance? Wednesday, the 12th of February, the committee will then be visiting the maternity hospital at 2 p.m. and this will also include a briefing on the children's hospital. So again, if members can confirm attendance in relation to that as well. Next Thursday, the committee's effective question and training session is in room 106 from 12:30 to 2:30 p.m. Lunch will be provided, and the committee meeting will then begin at 3 p.m. Are members content then to note the briefings are set out in the rest of the forward programme? Yeah. Any other business? No. Okay, members, so the next meeting is Thursday, 6th of February at 3 p.m. in room 29. So thank you. And just very quickly to mention, this is Roting's last meeting.
Committee room 29. Sound.